Am I audible, ma'am?
Yes, ma'am, you're audible.
Yes.
Okay, that's
Yes,
fine.
Bhavya.
Okay, we are like live on the YouTube now, and welcome everybody to the Obstetrics Symposium-II, which is on the cardiac. Okay, we are like live on the YouTube now, and welcome everybody to the Obstetrics Symposium-II, which is on the cardiac. Live on the YouTube now, and welcome everybody to the Obstetrics Symposium-II, which is on the cardiac. Live on the guys, is somebody actually got their
Phone on.
Obstetrics Symposium-II, which is on the cardiac. Live on the guys, is it
Same thing. Audio is coming again and again.
okay? Yeah. Are you able to hear me now? Okay. Yeah. So this is going to be the second the Obstetric Symposium on cardiac issues in pregnancy, and this has been led by Vanilla, and we have an excellent group of faculty who will be, giving sort of 3 lectures and discussions. And we also have an expert of cardiac anesthesia, which is Eisenmenger, who is with us as well. And thank you for joining us. So we have got Vanilla, we got Dhiraj Bhandari, we have Gurusanthiya, and we got Bhavya as a faculty. I'm going to hand over to Vanilla now to take you through the day. Over to you, Vanilla.
Thank you very much, Shiv. And once again, we have to thank you for this platform where we have an opportunity to learn and share. Welcome you all to the Obstetrics Symposium. As we are observing over the last decades, we have an increasing morbidity and mortality due to cardiovascular diseases, not just the infectious diseases and congenital heart disease spectrum in the low and middle income countries, but also the cardiovascular disease due to lifestyle and problems as reported in the latest data from the US as well as from the West. So we here have a big problem, as in women who are pregnant with cardiovascular changes and physiological changes, as well as a pre-existing or an acquired cardiovascular problem. So we today are going to discuss some interesting case scenarios, and we have expert faculty to discuss them with. First on board is Dr. Bhavya. Dr. Bhavya, are you here with us?
Yes, ma'am. Am I audible?
About peripartum cardiomyopathy, one scenario we all dread to have on table and in our labor room, but we would need to know how to manage so we can get the mom and baby home safe. Over to you, Bhavya.
Thank you very much, ma'am. Am I audible and clear?
Yes.
So peripartum cardiomyopathy is a problem which, as a prelude, I would like to say that there are many patients of peripartum cardiomyopathy that are diagnosed very late. And earlier they are diagnosed, better is the prognosis, because this is a potentially reversible situation. And if it is diagnosed late, it can be life-threatening, it can decrease the lifespan, and it can also lead to a permanent disability. So awareness amongst obstetricians and physicians is extremely crucial and important, and that is the aim of this presentation today. And I will discuss the presentation under epidemiology, pathophysiology, clinical course and management, the anesthetic considerations, prognosis, and a short take-home message. So the definition of peripartum cardiomyopathy, it was defined by the National NHLBI as well as the European Society of Cardiology. And they said that the development of cardiac failure in the last month of pregnancy or within 5 months of delivery, right? That is the main definition. The European Society of Cardiology made it a little more nebulous and said maybe towards the end or in the months following delivery. Both of them said that there should be an absence of any other identifiable cause of cardiac failure or a recognizable heart disease before the last month of pregnancy. And the consensus was that the LV ejection fraction at the time of presentation, as defined by the echocardiographic criteria, should be less than 45%. The National Heart Institute also said fractional shortening less than 30% or both, but the ESC stuck to the definition of an LVEF less than 45% specifically. So these two definitions differ a bit in the timing of diagnosis as well as in the cutoff for LVF, as I just explained. But simply you can understand it that it is previously undiagnosed cardiomyopathy 1 month before or 5 months post delivery in women who present with an initial LVEF greater than 45%. That is the broad definition which we must understand. So, as far as the epidemiology is concerned, the incidence of peripartum cardiomyopathy per 100,000 live births, it's the lowest in Japan and Malaysia. In the USA, it is around 1 in 1,000 to 4,000. And in India, it is around 1 in 1,500 to 3,000. So why is the prevalence of this rising? The prevalence is rising because there is more increased awareness, there is widespread eco facilities. So we have seen a surge in prevalence in the last decade as well. Now, the incidence also varies with age, as you can see very well through this slide, that more than 50% occurs in women over 30 years of age, here specifically 40 years of age. The odds ratio is around 10 in comparison to women less than 20 years of age. So the pathophysiology is actually very interesting, and the hormones of late pregnancy are implicated here. So here you can see the main organs involved are the pituitary and the placenta. And from the pituitary, the prolactin is released and it is cleaved. And once the prolactin is cleaved from a 23 kDa molecule to a 16 kDa molecule, then it starts playing havoc and it causes an impaired metabolism. And amongst the endothelial cells, it causes widespread apoptosis, capillary dissociation, vasoconstriction, and then at the microcirculatory level, there is an impairment. This leads to postpartum cardiomyopathy. The cathepsin D molecule, that is the main culprit, that cleaves the prolactin into the 16 kDa fragment, which is notorious. And it has also been found that an ST83 expression, if it is less, then a higher serum levels of 16 kDa prolactin are found in such women. So that is what led to the entire, all those studies and the rebirth trial, which started bromocriptine to prevent postpartum cardiomyopathy. This is the exact pathway that was researched and implicated. And as you can see from the next slide also, it is showing the exact same thing. There is a genetic susceptibility and there is an oxidative stress. These are the two main factors that are implicated here. They cleave the prolactin segment and they cause cardiomyopathy. And it has been seen that antisense on oligonucleotides were used in mice, and it was they decreased systolic function and cardiac fibrosis in mice. So an MIR 146A molecule RNA also blocks pathways, and this leads to cardiomyocyte death. So there are two mechanisms which are taking place here. If you want to understand it at a very simple level, there is an angiogenic mechanism and an anti-angiogenic mechanism. Now, when there is a shift from the angiogenic to the anti-angiogenic mechanism, then this entire cascade occurs, which I explained in the last slide. And especially there is one very important molecule which is implicated here, and that the name of that molecule is the soluble FMS-like tyrosine, or the SFLT1 molecule. This is the anti-angiogenic molecule which inhibits these vascular endothelial growth factors as well as the placental growth factors. And it is very interesting to know that during late gestation, this molecule rises in pregnancy, and it is also implicated in the endothelial dysfunction which accompanies hypertension. So these are the two molecules, and as you can see, there is a shift. Now, if you look at this slide, you will be able to clearly see that although the cardiac output is in black, although the cardiac output is rising in the first trimester, but the levels of these molecules, that is prolactin as well as the soluble tyrosine kinase, these levels peak near term As you can see, the surge near term, right? And they are also coinciding precisely with the incidence of peripartum cardiomyopathy, which shows that the etiology of this disease is rather vascular or hormonal and not the hemodynamic challenges which present in earlier pregnancy. So as far as the risk factors are concerned, we discussed the genetic mutations, the oxidative stress. There is a lot of ambiguity about what risk factors are there. A lot of research is going on, and this area is definitely a knowledge gap. So there are autoimmune mechanisms implicated. Some studies say there are iron or selenium deficiencies and anemias. Somebody says there's a viral myocarditis mechanism. It could be an inflammation. Anti-angiogenesis, I already explained. Of course, hypertension is definitely linked with cardiomyopathy, any kind of hypertension, either a chronic hypertension or a PIH or the preeclampsia that we study. And if there is a history of dilated cardiomyopathy, family clustering has also been reported. As far as race is concerned, there is a consensus, and several studies have corroborated this, that African American women show a 3 to 16-fold higher incidence, which is pretty massive. And the basic risk factors that are implicated are age more than 30 years, multiparity, and twin pregnancies. So in the next slide, we'll see about the genetic makeup. Now, you may say that we have already said that, okay, it has a genetic component, but precisely what is that genetic component? Now, there is a titin protein, which is very critical to cardiac muscle structure. It is a large protein which spans the entire length of almost half the length of the sarcomere, and it causes signal transduction as well as mechanosensing. So, this is responsible for the maintenance of passive and active tension in the heart. So how is passive resistance modulated in cardiomyocytes? Can you please press the button, Dr. Guru? So we'll have yes. It causes an alternative expression of the titin isoforms. And we have seen that only 15 to 20% of women with peripartum cardiomyopathy have these titin mutations. But 90% of individuals in the population that have titin mutations never develop any cardiomyopathy. So please remember that it is not mutually exclusive. Now, this is a beautiful diagram showing the entire molecule. What you have to remember is that the N2BA isoform is implicated in cardiomyopathy, which is the larger isoform, whereas the smaller isoform is there in a healthy heart. Can you please press the button so we can have the next images as well? Right. And please keep pressing. There are so fewer axons are expressed. There is less elasticity. That is in a healthy heart. But when the size is more, there is more of the titin. Then there is a less amount of passive stiffness, reduced passive tension, less diastolic forces, and this leads to a dilatation of the heart. So this is precisely how titin is implicated in the genetic etiology of cardiomyopathy. Now, an easy way to remember the risk factors, I've made a mnemonic for you, is I2MT2P. That is increased pregnancy and increased maternal age, more than 40 years specifically, malnutrition, twin pregnancies, and tocolytic therapies. And tocolytic therapies, you can remember, it's not my time. I for isoxaparine, N for nifedipine, M for magnesium, and T for terbutaline. Preeclampsia, smoking, family history, a history of obesity, and IVF, all these are risk factors which are implicated. And as you can see, the most important clinical features which are associated with here you have asthma as well, substance abuse, you have anemia, you have multiple gestation, preeclampsia, eclampsia, and hypertension, which have a p-value less than 0.05. So why is the diagnosis so often missed? That's a burning question which is in our heads all the time. The exact cause is always unknown. We are still not clear what precisely causes it. There is no single test currently existing to confirm the diagnosis. The heart failure symptoms during pregnancy, moreover, mimic the signs and symptoms that occur during normal pregnancy. Like a pregnant patient has fatigue, she has edema, she may have orthopnea, she may have dyspnea on exertion. So if all these symptoms are occurring and the patient is developing peripartum cardiomyopathy, it is more often masked. But the red flag signs are any signs of heart failure, if the patient is experiencing chest tightness, any signs of heart failure like tachycardia, increased JVP, a displaced apical impulse, a third heart sound, a systolic murmur of tricuspid or mitral regurgitation, pulmonary rales on auscultation, or peripheral edema. Classic history is that a woman has difficulty in lying flat for the exam. She is so dyspneic that she is not able to lie flat for the exam. So these clues, as you can see, these clues tell us that these are the signs and symptoms that will warrant further cardiovascular investigation, and especially if they are starting at more than 20 weeks of gestation. Remember, a diastolic murmur is always pathological. A systolic murmur can be physiological, but a diastolic murmur is always pathological. And if you have rales in the chest, cyanosis clubbing, or an S4 gallop, please press the button, Dr. Guru, so we can have, yes. So why is pregnancy precipitating all these problems in a patient? In a pregnant patient, we have reduced systemic vascular resistance, increased blood volume, aortocaval compression, and an increased heart rate and contractility. And all this is exacerbated due to the pain, stress, and blood loss during labor. And ultimately, all this has a very detrimental effect on the pregnancy physiology. So mortality in this group of patients is as high as 30 to 60%, and it is due to pulmonary edema as well as systemic embolization. So how do you diagnose these cases? Well, the first basic test that we do is an ECG. You can have a sinus tachycardia, you can have non-specific ST wave changes, you can have an LVH if the patient is hypertensive. The blood work I'll specifically come to in the forthcoming slide. And on an echocardiogram, as mentioned, the first paper that was written by Delican in 1971, he gave this definition of peripartum echocardiography precisely, an LVF fraction less than 45%, M mode fraction shortening less than 30%, and an end diastolic dimension of more than 2.7 centimeters per meter square. And I'd specifically like to mention here that the first reported case of PPCM was not in 1971, but it was way back in the 1800s, specifically in 1849, where very clearly, I even had the parchment, actually, I put it in another slide, but I could not share it here. It was a beautiful parchment where in the 1800s, the entire case of peripartum cardiomyopathy was shared. So you can imagine this problem was recognized around 200 years back, and we are still struggling with it. So the echocardiogram shows a global reduction in left ventricular systolic function. It could show various degrees of dilatation, not only left ventricle, but also right ventricular dilatation, a biatrial dilatation as well, any pathological murmur of an MR or a TR, and injection fraction which is 45% or significantly lower. Now, the chest X-ray is not necessary for diagnosis at all, but if necessary, or if you have to do it, or if you get it done, you should go do fetal shielding, and it will show an enlarged cardiac sulfate, pulmonary congestion, interstitial edema, and perhaps pleural effusions. A cardiac MRI is not a routine practice, but it can be done to confirm the diagnosis of a ventricular thrombus. And the American College of Radiology Safe Practice Guidelines in Pregnancy states that it is safe during pregnancy, but avoid gadolinium unless it is absolutely essential. So you have to do it without a contrast. A very important part of management of a peripartum cardiomyopathy patient, and not only management but detection, is a risk assessment. Now, if you feel that any patient coming to you has a history of cardiomyopathy, you must do a preconceptional risk assessment and counseling to determine the maternal and fetal risk of a potential pregnancy. A careful history, a precise physical examination, a functional capacity assessment of the New York Heart Association grade, a 12-lead ECG, and an echo is mandatory. Optional tests are a cardiac MRI if there is a congenital heart disease, or a right heart catheterization if there is severe pulmonary hypertension. But a history exam and FYH grading is very important. Now, what happens in an echocardiography? See, there is a basically in peripartum cardiomyopathy. We are not talking, peripartum cardiomyopathy may also have a restrictive component. It may have a hypertrophic component as well. But the most commonly reported component is the systolic impairment leading to a dilated CMP. So what happens here is that there is a progressive enlargement of either one or both the ventricles, and the interaction between the actin and the myosin filaments becomes extremely inefficient, and this leads to severely and permanently dilated ventricles with a low wall thickness to diameter ratio. So this causes a very remarkable or precipitous increase in the ventricular wall stress as well as oxygen demand, and this causes a reduction in stroke volume. The definition as given by the American Heart Association for diagnosing echocardiography in peripartum cardiomyopathy is this, where, as we mentioned, a fractional shortening less than 25%, an EF less than 45, the left ventricular end diastolic diameter more than 117% of the predicted value, an increased sphericity ratio of the length of the diameter of the length of the ventricle, severe impairment of the left ventricle that could be due to the presence of a, you can use a spontaneous echo contrast and also see for the presence of a thrombus. Then there is a diastolic dysfunction, and any case of diastolic dysfunction has a very poor prognosis. You may have a tricuspid annular proximal systolic excursion less than 14 millimeters, which again points towards right ventricular dysfunction, again a very poor prognosis. Frequently, mitral regurgitation is seen in these cases, and that may be either the cause or the consequence of DCM. So this is what you will actually see in the echo. This is the echo of a normal heart, a four-chambered view. And here you can see a left ventricular non-compaction cardiomyopathy, as shown in the upper right arrows, where you can see deep trabeculations here in the left ventricle. Now, when you come to dilated cardiomyopathy, you have enlarged LV diameters, as you can see here. And finally, if you have a case of hypertrophic cardiomyopathy, you have a thickened left ventricle, including the septum. The septum and the left ventricle is particularly thick. So this is something that you can see on the echo. So remember that this is a diagnosis of exclusion. So to avoid overdiagnosis, you have to pay very careful attention to the pre-existing heart disease of the patient. If the patient has any valvular heart disease or any other disorder. And remember that even severe preeclampsia can cause heart failure related to diastolic dysfunction. So PPCM is only diagnosed in the presence of systolic dysfunction. And if there are no risk factors, it's a 5% risk. But if there is even more than one risk factor, then there is a 75% risk of a cardiac event. So when we come to the blood work, as I mentioned earlier on the slide, the most important test here, there are three actually markers that are done. There is an NT-pro-brain natriuretic peptide, of course, our soluble FMS-like tyrosine molecule, and the tyrosine and the PGF ratio. So a normal level of pro-BNP is less than 300 milligram per dl. It's mildly raised in preeclampsia, which you might often have seen in patients if you had got this investigation done. But a level more than 1000 strongly indicates heart failure in these cases. And this is a test which the American Heart Association says that you must do if you suspect a patient having cardiomyopathy in pregnancy. Next, please. Now, suppose you get a suspected acute case here. So you can get an echo done and you can get these markers done. If they have normal values and if the echo is more than 45%, then you know that cardiomyopathy is unlikely. But if the values are abnormal, that is more than 1000, or if the ejection fraction is less than 45%, then you can think that yes, this patient may be having a cardiomyopathy in pregnancy. So the differential diagnosis is very important. You must always have a differential in your head. The patient could be having a valvular heart disease, maybe a congenital heart disease, simply hypertensive disorders, maybe a Takotsubo cardiomyopathy, viral myocarditis, any acute coronary syndrome, or even an HIV cardiomyopathy. Pulmonary embolism could also be, it's very common in pregnancy. And in fact, the first case that I mentioned in 1849, which was reported, that was a case of pulmonary embolism. So this is the differential diagnosis that you must keep in mind. Now, there are certain special tests that are done. I'll just mention them here. When a patient is positioned supine, it's very challenging because the IVC is compressed and the pelvic veins are also compressed by the gravid uterus. So you must always do a left lateral decubitus positioning. If you have to give an agitated saline contrast, it is safe, but remember it is a category B. Now, any intravenous echocardiographic contrast agents utilizing perflutrin on any lipid microspheres or any protein type A, you have to consider the risks versus the benefits, and please avoid them if other imaging strategies are available. A transesophageal echo, in case you have to do it, it is safe, but there is a risk in the required sedation, and also there is a risk of aspiration, so you have to proceed here with caution. And exercise stress testing can be safely performed in a pregnant patient, but you should avoid the pharmacological dobutamine stress testing. Now, here the management based on clinical experience and extrapolated from other forms of HF, you manage it in three ways. You manage the volume status. The best way to manage the volume status is to give diuretics. But while giving diuretics, you must remember the urinary perfusion is not compromised and the patient does not go into hypotension. Diuretics are definitely safe and you can give them in pregnancy as well as beyond. As far as the neurohormonal pathways are concerned, it's important to remember that the ACE inhibitors and the angiotensin receptor blockers here can only be given postpartum. You cannot give them in pregnancy. Beta blockers you can give both in pregnancy as well as postpartum. But with beta blockers, remember, the fetal heart rate and the fetal blood pressure can also go down. So you have to here also proceed with caution and monitor the fetal growth continuously, monitor the fetal heart rate continuously. Another alternative you have, sorry, and then you have to prevent thromboembolic and rhythmic complications. This is very important. Always keep that in the back of your head. So, what is the approach? Anti-failure treatment in pregnancy before delivery requires modification because you have to ensure fetal safety. But after delivery, most of the heart failure medicines they are compatible with breastfeeding. The main aim of our treatment is symptomatic relief, control of heart failure, and improvement of long-term outcomes. So basically, we will optimize the preload if the patient is in distress. If we get a patient of severe peripartum cardiomyopathy with distress, we will optimize the preload. We will give diuretics. We can also give vasodilators like hydralazine if the systolic BP is more than 110. Then, of course, oxygenation, either an IV or invasive ventilation. If the SpO2 is less than 95 and the patient is desaturating, we can add inotropes and vasopressors. You can consider levosimendan as well at zero point 0.1 mics per kg per minute. You have to get an urgent delivery done. You can consider bromocriptine, 2.5 mg BD, the starting dose, and the QID subsequent dose. And if the patient is severely, the ejection fraction is less than 25%, you will have to consider mechanical circulatory support. And so here is a table which I have made, and simplifying all the drugs. This is a very important table actually, because you have to know which drugs you can use during pregnancy and which you can't use. So loop diuretics you can use both in pregnancy and beyond, as well as beta blockers. The side effects I discussed earlier. ACE inhibitors and ARBs, remember, you cannot use them in pregnancy, but yes, you can use them during lactation. Mineral corticoid receptor antagonists, again, the same. You can't use them in pregnancy, but in lactation, you can use them. Hydralazine and nitrates, you can use both in pregnancy as well as lactation. And this is the actual chart of all the drugs. They have tabulated them very well in the American Heart Association, but I just simplified the chart for you so we can proceed. So as far as the treatment is concerned, the treatment involves BORD. BORD is a mnemonic which was developed by the American Heart Association with bromocriptine, which is given 2.5 mg daily for 7 days. And you can give it for a longer duration in severe cases. If the patient is responding, get subsequent echos done and see if the patient is responding. Then oral heart failure drugs, after stabilization, you can give a beta blocker, you can give an ACE inhibitor. You have to anticoagulate the patient because bromocriptine causes deranges the coagulation. So anticoagulation here is very important. And moreover, as all of us know, pregnancy is a hypercoagulable state. Then you can give relaxants like vasodilators if the systolic BP is more than 110 and if the BP permits, and of course diuretics. So this is a good mnemonic for the treatment. And then we'll proceed to the clot formation in PPCM, which is a very major risk. It is caused because of bed rest, because of dilated hypercontractile chambers, maybe if the patient is in AF, or due to bromocriptine use. The thromboembolic complications are 10%. Echo evidence of clot is also in 10% of patients, and anticoagulation is definitely indicated for treatment. So warfarin, because it crosses the placenta and it is teratogenic, but it is compatible with lactation, so you can give it after the baby is delivered. Directly acting anticoagulants, they are not recommended because there is a lack of data. But nowadays, there are some studies which have started giving them, but still the data does not substantiate them to give them widespread. Now, unfractionated heparin and low molecular weight heparin do not cross the placenta, so they can be safely used. There is a higher rate of thromboembolism in peripartum cardiomyopathy than other forms of HF. And this is because pregnancy, as we know, is a hypercoagulable state. It is an evolutionary adaptation to minimize the hemorrhage. So the AHA guidelines on dilated cardiomyopathy, they say that anticoagulation should be done for women with an LVF less than 30%, especially those who receive bromocriptine, and the level of evidence is level C. And Colty et al. Also did a study on this where they found that the most common complication, that is in 6.6% of the patients, was thromboembolism. And it's basically due to the cardiac dilatation, endothelial injury, and immobility that is present. Again, another complication is arrhythmias. Again, the AHA has given guidelines for this and said that it is reasonable to allow for more than 6 months of optical medical therapy in patients to allow for myocardial recovery when you are considering the placement of a cardiac device, such as an intracardiac defibrillator or a cardiac retonization therapy. But if a patient is a high-risk patient with an LVEF less than 35%, then that patient can wear a wearable defibrillator life vest. And this is although considered as a bridge to LV recovery or ICD implantation 3 to 6 months after. So you can give these patients inotropes, the severely affected patients with a ejection fraction probably less than 30 or 25. You can give them an intra-aortic balloon pump, a biventricular assist devices, and in severe LV depression or cardiogenic shock, you will have to give ECMO. But you must be very, very aggressive in treatment because these patients do bounce back. They do have a high recovery rate. So we must, try our utmost to do whatever possible to save them. In the obstetric management, if the patient is unstable, a prompt delivery should be done. And if possible, a vaginal delivery is preferred. Delivery through cesarean section should be reserved only for those patients who are critically ill or if there is any other obstetric indication for that. So in the preoperative preparation during the PSC checkup, you will see what the patient is on. And if the patient is on ACE inhibitors, it can cause hyperkalemia, renal dysfunction, intraoperative hypotension. So you will have to stop it. Diuretics also, they can cause dyselectrolytemias. Anticoagulants, you have to check the INR once. If you are planning an epidural or a spinal is highly unlikely, but if you are planning an epidural, beta blockers you can continue if the patient has been on beta blockers previously. You do not have to initiate it in less than 24 hours before surgery. As far as the antiarrhythmics are concerned, you can continue digoxin and you can start statins also if the patient has a pulmonary peripheral arterial disease. Now, if the patient has an intracardiac device or is on cardiac recontransation therapy, you will have to reprogram it. You will have to deactivate the anticardiac function, and you will have to keep all the inotropes, the pacemakers, the defibrillators ready during the case. So this is the preoperative preparation which you do. Now, a good way to make a decision is that if the patient is NYHA grade 1 and 2, you can go for a regional anesthesia, but if the patient is an NYHA grade 3 and 4, you have to proceed for general anesthesia. Regional anesthesia is not safe. So the advantages of regional anesthesia are that the central neuraxial block, it decreases the afterload and it improves the cardiac output. And the accompanying hypotension resulting from the myocardial hypoperfusion must be prevented by co-loading or preloading the patient. Always prefer a graded epidural, that is, give the epidural in aliquots rather than giving a whole dose. Now, the goals are this. You have to prevent an increase in afterload. So, oxytocin, which decreases the SVR, and ergometrine, which increases the afterload, also should be given judiciously. You have to avoid the drug-induced myocardial depression. You have to preserve normovolemia as well as preload. Remember that there is impaired circulation for IV anesthetic agents, and you have to prevent sudden hypotension by careful titration of the volatile anesthetic agents as well. Because whenever there is impaired contractility, there is a reduced cardiac output, and this leads to an increased ventricular diastolic filling and volume. And this ultimately leads to an increased end diastolic systolic volume and a reduced systolic ejection fraction because the heart is dilated and it is just lying there. You have to watch for arrhythmias, emboli, and sudden cardiac death. It is very common in these patients. So for monitoring, you can use arterial as well as central venous catheters. If you have TOE, a transesophageal echo at your disposal, you can get a dynamic assessment of the myocardial function. And a bispectral index monitoring, if possible, you can use it to titrate anesthetic agents. Moreover, if you have cardiac output monitoring available, whether minimally invasive, you can use that as well. And that will help you to give fluid to the patient very judiciously. In inotropic support, you can give this patient phosphodiesterase inhibitors, levosimendan, dobutamine, and dopamine. Dobutamine, definitely you might have to start in the postpartum period if the patient is in cardiogenic shock. Noradrenaline you can give to prevent hypotension and also to prevent sudden increases in afterload. Biventricular pacing and an intra-aortic balloon pump will have to be done in patients with severe systolic dysfunction. So mortality is 3 to 28% and recovery takes as long as 2 to 6 months. So in the ICU, invasive monitoring is required. You have to optimize the hemodynamics as well as the fluids in the ICU. You have to be very careful, not overload the patient at all. And you have to give adequate analgesia, keep the patient pain free so that the deleterious effects of increased SVR are avoided. In the postpartum period, remember, uterine bleeding is a concern. So you can give uterine massage and low dose, remember low dose intravenous oxytocin, because oxytocin may lead to an increase in the afterload. And what happens is that the postpartum period is a very, very dangerous period because there is redistribution of volume after delivery, especially 12 to 24 hours. All the volume of the placental circulation is reabsorbed into the systemic circulation, and this causes a severe reduction in LV systolic function, um, with severe gradient, increased risk for developing heart failure and symptoms and pulmonary edema during this period. So you have to continue the beta blockers. You can introduce low dose ACE inhibitors also, and if there is persistent systolic dysfunction, you should continue the heart failure therapy of the patient indefinitely. There is no timeline. If there is no improvement for 6 to 12 months, there is unlikely to be any improvement later as well. But if the EF is 35 months, after 6 to 12 months, if the EF is 35% after 6 to 12 months on optical medical therapy, then you must think about either an ICD and implantable cardiac defibrillator or cardiac resynchronization therapy. If the EF of the patient is normal for 6 months, then you can slowly wean them off the device and get an annual echo, ECG, and a cardiology consultant. Now, there are predictors of good recovery, poor recovery, and mortality. If the patient presents early with a mild presentation, shows a good response to treatment, EF is more than 30%, there is no clot, and the pro-BNP is also less than 1000, then this patient has a chance of making a good recovery. But if the diagnosis is delayed, the patient is in gross heart failure at the time of diagnosis, there is a poor response to treatment, ejection fraction is less than 30%, the chambers are grossly dilated, you can see an intramural thrombus there, and the pro-BNP is more than 1000, then these are predictors of poor recovery, and you have to prognosticate and explain it to the family as well. Now, the mortality is around 70% of the patients recover fully, 15% partially, and 13% they continue to have LV dysfunction. So this is another chart which is just explaining the same thing. Let's just skip to the next slide. This is a beautiful diagram which was made by the JACC, American College of Cardiology, and they have summarized everything that I have just explained to you. So the definition, the management options, and the outcomes as well as the long-term outcomes. So if a patient is planning a subsequent pregnancy, it's very important that the patient should be properly advised, because a full recovery does not predict a risk-free subsequent pregnancy. A multidisciplinary team should be involved here with a cardiologist, obstetrician, maybe a fetal medicine specialist, neonatologist, and even a psychiatrist, because these patients, studies have shown that they are prone to mental health problems and psychiatric diseases. Relapse rates are unacceptably high in those who have recovered partially, and mortality rate is very high if it occurs during the next pregnancy. Those who have received bromocriptine during previous pregnancies and recovered fully can be allowed. So the take-home points here are that this is a condition which requires a multidisciplinary team. The diagnosis of it's a diagnosis of exclusion. You have to be very, very vigilant. and have a low threshold for testing. No biomarkers are specific, including troponin T, troponin I, B, natriuretic peptide, or the N-terminal proBNP. They are not specific. They have been implicated, but they are not specific. Bromocriptine has been given in postpartum women in severely depressed LVEF, although the safety and efficacy has not been established. But one German and two African studies showed promising results. The 2018 guidelines of the European Society of Cardiology, they said that it's a level of evidence too, and they said it's useful only when started early, but it is still not approved in USA and Canada. A rebirth trial of bromocriptine is going on, and we will have the results probably after 2 years. You have to remember the medications which are safe for heart failure in pregnancy as well as medication safe for lactation. Contraceptive counseling for the patient is very important. You have to explain the risk of subsequent pregnancy. You have to be very vigilant in terms of your hemodynamic monitoring as well as fluid administration. A choice between regional and general anesthesia should be made intelligently, considering the hemodynamic status of the patient. And the postpartum period is the period of utmost concern where you should be extra vigilant in these patients. So, thank you for your attention. And
Thank you, Dr. Bhavya. That was indeed quite a comprehensive cover of peripartum cardiomyopathy. Thank you very much. It was quite good to revise and go through the pathophysiology and the implication of some of the chemicals. I just have a question. Does anybody else have a question for Bhavya? Dr. Amarja, would you like to add anything?
Yes. Good evening, everybody, and thank you very much, Dr. Vanilla, for having me here today. Excellent talk by Dr. Bhavya, and I appreciate it. There are a few points. I have got one question on the YouTube also. We will answer that. But firstly, let me highlight a few things. Like mostly we have dilated cardiomyopathy in the peripartum period. So we have to always have echo handy, and if you are used to doing echo, nothing like it when we get such patients, and we can easily pull through such situations. For that, you have to scan the LV, RV as well. The second thing is, once you know that it is dilated cardiomyopathy or hypertrophic cardiomyopathy, the two have totally different line of managements. Yes, that is very important. In case of dilated cardiomyopathy, you may have to start inotropes as such. You may not have to give fluids. But in case of obstructive, if it is there, or hypertrophic cardiomyopathy, it may be associated with SAM, which is systolic anterior motion, which causes LVOT obstruction. So the treatment of that is totally different, like volume loading of the patient, starting beta blockers, and again vasoconstriction, giving vasoconstriction. So this is very important that we all should know which type of cardiomyopathy is there. Usually these patients present with dilated cardiomyopathy, but we should know both of them. And secondly, this was about the type of cardiomyopathy. Second is the arrhythmias. We have to deal with the arrhythmias also in these patients, which can be dealt with, as she has already told, digoxin, Cardaron, Lasix, and also you have to monitor for K-salt. K-salt means potassium levels, and administer K-salt as and when needed. Okay. Cardiac failure is also third thing which you have to keep in mind always. Okay. And now take home message from my side is that you have to always have two inotropes handy. One is noradrenaline, which is our favorite always, and second is the dopamine. Okay. The bromocriptine, which she was telling every now and then about bromocriptine is actually dopamine agonist only. So we actually have a good inotrope, vasoconstrictor, and a chronotropic agent. That is all the three we have in dopamine, and which can be very well started with 5 microgram per kg per minute initially only. And noradrenaline is always there for the vasoconstriction that we need, or hypotension if it occurs. Regional anesthesia, yes, I prefer always epidural, graded epidural, as already has been discussed. As and when required in severe cases, GA has to be given. Okay. And now one last question I saw in the YouTube, which AC inhibitors can be given, someone has asked. Actually, AC inhibitors are not indicated in the lactational mothers, because there are studies where they can cross the breast milk, and if consumed by the babies or the preterm babies, can cause hypotension in them. So but they say that much quantity, they don't have that much studies also to say thoroughly that it should not be given. So I think it has to be a multidisciplinary approach, and with discussions with your cardiologist, anyways we don't prescribe them, but we should always know what is happening with the patients. Yes, that was all from my side for this topic.
Thank you, Amarja. Thank you very much for summarizing how we actually categorize. With regards to Lasix, I think that was one thing, because these patients, we have to be quite careful about the dosing of Lasix as to titration of Lasix instead of bolusing big doses. I think they can be quite susceptible to the vasodilatation and immediate collapse on table if we are actually dealing with them on table. I mean, the question that I wanted to ask was, if we already have a diagnosed patient, either in the second trimester, first trimester, I think we have to decide whether they actually want to proceed with the pregnancy or not. And second, I think they'll be given a choice depending on the severity of the disease, and or the cardiologist and the entire obstetric team and anesthesiologist, we have to decide. However, if they are in labor room and they are actually closer to delivery, then the aim is to get the mother and baby safe, optimize the mother, anti-failure, cardiac optimize, deliver her either vaginally or by C-section, and get her to the cardiac team so they can safely take her home. However, if it is an on-table diagnosis, as in how do we arrive at that, I think that's how we have to go through the differential diagnosis. Bhavya or Dhiraj, would you like to add anything for this?
Ma'am, we often get patients in our emergency who come to us from the periphery, and they have no investigations. They just come in heart failure, and we have to proceed with those patients. So at that time, I think ascertaining the cause is not as important as just managing the patient on table. And once the patient is managed, then we can do other investigations and then try to ascertain the exact cause of heart failure. But if the patient comes to us straight from the periphery, then the management is more important than the exact cause.
Yes, I think managing airway, breathing, circulation, I think maintaining the normoxia and normocavia. But as Amarja pointed out, the one tool that we all would like to have is an echo, if possible. I think most of us are, lucky enough to have that with us, but not many hospitals will have. So if at all there's any sign, I think identifying these high-risk mothers in the periphery would be the first key, so they can actually get round to a better center. I think when we need to refer these patients is, I think, a very important point. But if we end up having them, then we have to deal with them as per the protocol. Dhiraj or Guru, do you have? I think I just noticed Dr. Achal had joined. Is he?
Yes, he is with us.
Would you like to add, Dr. Achal?
Yeah. Hello, good morning here. I joined a little bit late, but it is always nice to collaborate and see and chat with our friends. I personally do not do OB, but I always have interest in cardiac. And I have written a book chapter also, cardiac issues in pregnancy in one of the books. I just want to make a couple of points. It was very nice presentation, Bhavya. Congratulations. We have in our group as one cardiac anesthesiologist always who does OB. So that means any high risk OB related to cardiac issues, whether it's congenital, pulmonary hypertension, or heart failure. So we should always refer that patient to him or her. That is one thing. In very rare conditions, our OB suite is totally separate in a different hospital, different location in the city. And sometimes, or not sometimes, I should say, rarely we transfer those patients who are very high risk to our cardiac operating room and deliver them either under GA or epidural. with the cardiac surgeons, cardiac anesthesiologist background. For example, patient who has got huge, big aortic aneurysm, patient who has got severe pulmonary hypertension who can collapse, or patient with ejection fraction, say 15-20%, may require an urgent, not IABP, maybe some kind of LVAD device or something. Or sometimes our perfusionists or cardiac surgeons go to that hospital to provide that kind of support. I think that is only thing I can add, because I'm not an OB person at all. So I'm here to listen. Thank you.
Thank you, Dr. Achal. Yes, Bhavya.
Thank you very much, sir. And I'd just like to add that if we get a patient and that patient is not responding to inotropes or vasopressors in the postpartum period, then definitely that is a case that you should refer to the cardiac team, because then that patient will require probably an advanced form of treatment, a treatment of advanced heart failure, which is not possible in the obstetric suite.
Yeah, I'd just like to share one slide, if I may. It's just about whom to do and where they should be done. I think that is where we all should know, because a regular obstetric general anesthetist, as opposed to an institutional obstetric anesthetist who has all the facility with them, as opposed to a general anesthetist who does obstetrics, every day on a regular basis, but doesn't see high-risk patients. We have to differentiate between this wide spectrum of anesthetic group that we are addressing today. If you're a simple general anesthetist and you do your bread and butter, but you see a really sick patient who's unable to lie down flat, and you are thinking there is a murmur, you don't have an echo, and you don't actually see, you see there are red flags coming up, all that was pointed out in Bhavya's, even though if you don't have a diagnosis, you have to shift this patient to a higher center. I think that is the bottom line we would like to emphasize. If you're in an institution and you can call for help, somebody with a cardiologist, somebody who can actually put a pump or help you with the defibrillator, somebody who actually knows the protocol along with your side in an obstetrics center, then you can deal with the problem by calling for your phono friend, as we always say in our gas symposiums. You can call them for help and do it if you have the facility to do that. However, it's different if you're in a medical college or an institution, or you have a cardiac anesthetist next door to you. Then life becomes easier, because you just shift from this theater to where the ECMO is or the bypass is, and you can save the life. So I think the bottom line I would like to say here is, you need to recognize the red flags before you put a spinal in or before you put a tube down. Yes, if the patient is already going downhill, you stabilize and shift. But if the patient has got few hours, then that golden hour or few hours for stabilization in the labor room, you need to know where to shift. I think that is one line I would like to mention to you, because it saves your life as well as the patient's life and your entire career. I just like to share this one slide, or if I may. I think anybody else like to add anything?
Vanilla, there is a question again. What are the non-obstetric indications to terminate pregnancy in case of PPCM?
Okay.
So I think the non-obstetric indications might be a very severe cardiac failure in case of these patients having very severe mitral regurgitations, throwing arrhythmias, or severe RV dysfunction, and these patients are not yielding to any kind of treatment. These are the patients who are intubated, who are on high inotropic supports, and still the saturations are not coming up. Yes. And they may not have the higher facilities to undergo ECMO or LVAD. These are few indications that before the baby gets compromised, maybe to save life of the mother. These are the few indications.
Yes, thank you, Amarja, for answering that. Yes, we want to prevent hypoxemia to the mother and the baby. Make sure they're oxygenated. And we don't want to overload or underload if we don't have a diagnosis or an echo. So you go with the clinical signs, get some lines in, get airway, breathing, circulation intact, and then shift them to a higher center. I think that would be the bottom line if you don't have a facility. If you do have facility, then we have to empower ourselves and our team to deal with such situations. I think that is, and if we do, then we need to follow the protocol and get some help. So this is just a beautiful slide that came up in the circulation journal with regards to how to deal with mothers with cardiac diseases. First is, if you actually have the time and see them in the antepartum, you assess the patient's condition, risk stratify them, and identify if she has a disease. Then, can she actually have a vaginal or a Caesar delivery? Are we able to do that in our place? Is it going to be term, early term, or do we actually, if she's decompensating, should we terminate it now? Which type of center? I think this is very, very important for us, where we don't actually have a uniformity in system across our country. So we need to have a practice where we know which patient, we identify red flags, we need to send them across. And that is why the risk factors slide was very, very important. If you have to put the points together to know that this is a high risk patient, to send them across. And how and plan, I think once we have the facility, I think the protocol we have to follow, where whether it is regional or general, we need to tread on a small line where we don't overdo the or dilatation or vasoconstriction. I just stop with that. Anybody else like to add anything?
I just want to ask you people a question, like how many times you prefer epidural anesthesia or spinal anesthesia? Because I have seen my colleagues in my hospital giving spinal anesthesia very well to these patients and managing very well. They don't go for epidural also. In case if there is a choice of general, in that case, in very severe patients, they give general. But they manage patients very well under spinal anesthesia. So what is what do you do, or your experience like?
You're asking me, Bhavya?
Yeah, everybody who.
Yeah, I think we have all learned over the years to give a small dose spinal or isobaric spinal as well.
And nowadays, additives are added.
Yeah. We have learned, try to avoid, because we have learned, I think, with experience, how to deal with them. But again, if the patient is in failure, not treatable, then I think I've had situations where we had to go in for GA. But yes, I think I mentioned to you once where I had a patient where we had to do a spinal. So we are moving more towards spinals.
Yes. So many times we talk about epidural, but actually practically we use spinal a lot.
Actually, the most important thing is in epidural, it takes time. Most of the times these patients they're called in emergency. We are called for emergency section. So if we judge on the table that the patient is deteriorating fast, and if it is manageable, of course, in that particular nursing home, then we'll go for spinal, low dose spinal, as Vanilla said, because epidural takes time to act.
Yes.
And many times this thing is not proper. The relaxation is also not proper.
Yes.
So the obstetrician also is not happy.
Yes.
And here we want to to take out the baby as fast as possible. So that is, and if the GA of course, if the GA facilities are not that good, then spinal becomes the.
May I jump in here?
Yes, sir, please.
Okay, Shiv, you want to say something? Then I will follow you.
I just wanted to actually ask a question. This is especially to the people who do cardiac anesthesia. I know you've just been talking about that there's no facility of ultrasound. I think that's actually wrong. Most obstetric centers actually have got ultrasound, and they can't actually do anything without ultrasound.
Yes.
I know you guys use a phased array probe for the cardiac evaluation, but it's very much possible actually to use a curvilinear probe to know at least, I mean, you don't need exact figures, but you can actually make out whether this is going to be a hypertrophic cardiomyopathy or is going to be a dilated cardiomyopathy. I think most anesthetists doing obstetric anesthesia can learn that very, very easily, because like I think which was very clearly pointed out that the management of these two are totally different. And if you can teach them just this simple thing that, okay, you put a probe here, you can actually make out, just by eyeballing, you can make out that whether this is a hypertrophic cardiomyopathy or this is going to be a dilated cardiomyopathy. I think you can actually change the way these cases are managed. Dr. Achal?
Yeah, thank you, Shiv. I totally agree with you. I would just say that the tide and the time are always with the ablest of navigators. If you know what you are doing, you know what type of problem you are facing, and you know what resources you have, you can manage most of the problems. So even coming to that question of spinal anesthetic, we know that spinal causes vasodilation, simple as that, and that it causes hypotension. So if the same patient would come to me and there was no OB anesthesiologist, I would simply give full dose spinal anesthetic. No, full means which is relevant for the OB patient, and manage the systemic vascular resistance by some NOR-IP infusion or some phenylephrine infusion. So just counteract that. So we know how to play with that. And so spinal, I totally agree. There's nothing wrong with it, as long as you know how to manage the hypertension of it. And second thing, what Shiv mentioned, these any ultrasound probe, it is an ultrasound. What kind of probe it is doesn't matter, as long as it gives you pictures of the heart. And with that, quickly, it can answer your questions. Heart is empty or full. Is it beating adequately or not? Is it thick or it is very dilated heart? So those questions you want to know, and then manage your patient accordingly. Thanks.
Thank
Shall we
you.
move on, Vanilla, to the next session then?
I think so.
Because
Thank
I
you.
think I must actually say, congratulate Bhavya. There's a lot of, I think it was a wonderful presentation, and a lot of people actually have messaged on the YouTube about that this was a really, really excellent presentation. Thank you, Bhavya. And
Thank you very much,
over
sir.
to you.
Thank you for the opportunity.
Thank you, Bhavya. We now move over to our next speaker, Dr. Gurusanthiya from Coimbatore. She's going to give us a quick review on congenital heart disease and pregnancy. How do we deal with such group of patients? Over to you, Guru.
Thank you, ma'am. Am I audible and clear?
Yes.
Okay. My topic is about congenital heart disease and pregnancy. These are the patients, subset of patients who are presenting to us in increased numbers because of the advanced healthcare. So these congenital cardiac diseases can be a left to right shunt, which includes ASD or an atrial septal defect, ventricular septal defect, and a patent ductus arteriosus. When case of a right to left shunt, which can be a tetralogy of Fallot or coarctation of aorta, a Fontan circulation, which is done for is a surgery which is done for a single ventricular physiology, or the patient can have a left to right shunt and can present to us in an Eisenmenger, or iotropathy in case of a congenital valvular heart disease or vascular events or a connective tissue disorder, and congenital valvular lesions. So these patients, because of the physiological changes of pregnancy in preload, afterload, heart rate, and contractility, these patients, depending upon their primary lesion or residual lesion after repair, may pose an increased risk of heart failure, arrhythmias, and cerebrovascular accidents. And hence, it is imperative to have a planning for a delivery. And this was discussed by Dr. Vanilla before, and this includes identifying the patient who are at increased risk by a scoring system and assigning the high-risk patient to a pregnancy heart team, and when to deliver and what mode of delivery depends upon what congenital heart disease the patient has got, and will the patient tolerate a vaginal delivery, or should we terminate early because of the decompensation because of the congenital heart disease. And where to deliver is utmost important, and it was discussed before as well. And any patient who has got a higher degree of scoring system should be delivered in a level 4 maternity care or a tertiary hospital, which encompasses an obstetrician and an in-house cardiologist. And most important part is the anesthetic management and monitoring of these patients in the peripartum period. This is a modified WHO classification of any patients who has a cardiovascular disease, wherein class 1, there is no detectable increase in maternal mortality or a minimal increase in morbidity, which is around 2 to 5%, where the congenital heart disease, which comes under this category, or any repaired ASD or VSD or PDA, or any uncomplicated mild pulmonary stenosis and PDA. In class 2, there is a small increase in the maternal mortality and a moderate increase in morbidity. Any unoperated ASD or VSD or a repaired tetralogy of Fallot and any arrhythmias which would follow these patients are categorized under class 2. Class 2 to 3 is a moderate risk of maternal mortality and morbidity. Any patients who have got a Marfan syndrome or hereditary aortic diseases and repaired coarctation of aorta without any residua and atrioventricular septal defect falls under this category. And class 3, there is a significantly increased risk of maternal mortality, and that includes a systemic right ventricle in a single ventricle with a good or mildly affected LV function, or an uncomplicated Fontan, or a tetralogy of Fallot, or any cyanotic heart disease which is unrepaired, and a moderate aortic dilatation which is around 40 to 45 millimeters in case of Marfan's, or a bicuspid aortic valve with aortic root value of 40 to 45. And pregnancy is highly discouraged or contraindicated in class 4 patients because they decompensate and the mortality is so high, around 70%. And the causes include severe pulmonary artery hypertension of any cause, severe aortic dilatation more than 50 millimeters, and any Fontan circulation with the complication. And there are other scoring systems also, which is CARPEC-2 and Zagara, which addresses the patients with cardiovascular disease and risk stratify them according to their values which are present in the prenatal period. And pregnancy heart team should encompass and high scoring, or the patient who has got a score 3 or 4 should be managed in a tertiary care center where an obstetrician, and as said earlier, an anesthesiologist who is a trained obstetric anesthesiologist, and an in-house cardiologist and a neonatologist who are present. And in case of a patient who is at dire risk and who are in need of a support by a cardiac surgeon or a vascular surgeon in case of aortic dissection, such centers must be chosen for delivery in case the patient is rapidly deteriorating. So coming on to left to right shunt, which is basically atrial septal defect, ventricular septal defect, and patent ductus arteriosus. Increase in cardiac output and physiological changes during pregnancy actually increases the left to right shunt and causes the increase in PA pressures. These both are counteracted by decrease in SVR, which favors the forward flow up into the aorta from the LV. But during the labor and delivery, we must have an utmost caution to have our goals to prevent extreme tachycardia and to avoid any further increase in the SVR, because any further increase in SVR will actually cause the shunt from the left to move towards right, and there will be increase in left to right shunt. And we have to maintain the PVR in case the preoperative PVR is normal. In case the preoperative or pre-pregnancy PVR is itself is increased, then we have to decrease the PVR in the interim period of labor and delivery to have an effective outcomes. These patients, they do not tolerate hypovolemia and optimal fluid balance, and looking out them for any dysarrhythmias in case of atrial dysarrhythmias and heart failure because of increased volume overload is necessary, and that is our goal. And in case of left to right shunt, which can be taken as a tetralogy of Fallot, pregnancy-induced changes which are increase in heart rate on cardiac output and accompanied by a decrease in the systemic vascular resistance will actually worsen the left to right shunt, and it will cause cyanosis in such patients. Any pain or stress or labor or catecholamine stimulation will act as a dynamic obstruction across the infundibulum to increase and will precipitate left to right shunt and cause further worsening of cyanosis. So in these patients during labor and delivery, we should maintain the systemic vascular resistance. We should maintain high central pressures, because preload, if there is a decrease, then the RV will not pump and it will lead to any cyanotic spells, and hence maintaining high central pressures in these patients is of utmost importance in right to left shunt. And any myocardial depression using a beta blocker for any heavy tachycardia, or in the interim period using an increased dose of our anesthetic agents is not indicated, because such conditions will lead to right ventricular failure in such patients. Coming on to iotopathy, which may be because of a connective tissue disorder or a Marfan's or an Ehlers-Danlos loss. These patients, because of the changes in pregnancy, they have increase in the aortic root dilatation or aortic dilatation, and are at increased risk of aortic dissection in the pregnancy times. During labor, the maternal Valsalva, which is actually done against a closed glottis to aid in the labor, is actually associated with increased aortic shear stress and can lead and precipitate an aortic dissection in such patients. And in such patients, it is imperative to decrease the duration of second stage of labor, either with the forceps or an operative delivery is indicated if there is already an aortic dissection. Our perioperative goal is to minimize the aortic wall tension, either using a beta blocker or an vasodilator, and we should minimize any hemodynamic fluctuations which would occur. And in such patients, if the patient is already having a pregnancy-induced hypertension, then we should treat it very aggressively to prevent the risk of aortic dissection. And any patient who has a aortic valve area or diameter of more than 50 millimeters of mercury, it is actually better to go for a cesarean delivery rather for a normal delivery. And coming on to coarctation of aorta. In coarctation of aorta, the LV is actually pumping against a fixed obstruction, which is to its ejection. So coarctation is basically fixed. So any increase in cardiac output should be done only by increasing the heart rate, and stroke volume cannot increase further. So pregnancy, there is actually increased volume, but the patients will have elevated baseline heart rate, because to accommodate for the increase in cardiac output, their heart rate must increase because stroke volume cannot increase further. So depending upon the severity of coarctation, the patients will present to us either in an LV failure, or if the coarctation is very less severe, then the patient may not have any further symptoms and may tolerate the pregnancy well. Because of the increased shear stress, these patients are at risk for dissection, and the blood flow below the coarctation is actually very less, and it can lead to decreased uteroplacental circulation and can have a risk of IUG or fetal mortality and so on. And the perfusion below the coarctation is actually very surplus, and if the patient has got any pregnancy-induced hypertension or hypertension per se, it can lead to intracranial hypertension and can precipitate eclampsia. So our primary goal is to maintain the SVR, because any further decrease in SVR below this coarctation will actually not have, the LV will not contract against a low SVR and pump it against, and hence maintaining the SVR with vasoconstrictors using phenylephrine or norepinephrine infusions during labor or labor analgesia or a cesarean section is of utmost importance. Since heart rate, the tachycardia only maintains the cardiac output, bradycardia is very, very poorly tolerated in such patients, and maintaining sinus rhythm to maintain the atrial kick is important, because the forward flow depends upon the LV end diastolic volume and pressure. In case of pulmonary artery hypertension, the RV is pumping against a fixed obstruction or a narrow pulmonary artery. So increase in cardiac output and preload during pregnancy can precipitate a right heart failure, and decrease in the SVR during pregnancy will lead to a decreased right heart perfusion and lead to right ventricular failure as well. Since these patients, pregnancy itself is a hypercoagulable state, and these patients have an ordered hypercoagulable state, and these patients are put on anticoagulants in the pregnancy period time as well. And these patients will not tolerate any further increase in fluids, and hence optimal fluid balance is necessary, and oxygen supplementation during labor, may it be normal delivery or assisted delivery like labor analgesia, oxygen supplementation is of utmost importance to decrease the PVR, and to any measures which increases the PVR, which includes hypoxia, hypercarbia, pain, hyperthermia, all that should be avoided in these patients and should be meticulously followed, and myocardial depressants, if any, should be avoided in the perioperative period in these patients. Coming on to Eisenmenger syndrome, these are the subsets of patients who initially have a left to right shunt. Due to the progressive increase in flow across the left to right shunt, these patients' pulmonary system will undergo remodeling and will have a fixed obstruction and will develop increase in pulmonary vascular resistance. When the pulmonary vascular resistance is more than the suprasystemic pressures, or when the pulmonary vascular pressure is more than the suprasystemic pressure, there occurs a reversal of shunt. The shunt can be bidirectional, or it can be a right to left shunt in case of an Eisenmenger. So heart is basically pumping against a fixed pulmonary vascular resistance in Eisenmenger. An increase in cardiac output or decrease in SVR, heart rate, and blood volume will actually worsen the shunt and cause reversal of shunt and cause the blood flow to flow from right side to left side and lead to RV failure. And in such patients, we have to maintain the systemic vascular resistance because any further drop will actually accelerate the right to left shunt. And these patients depend upon RV preload for their forward function. And any further rise in PVR should be strictly curtailed. And there have been studies which have used inhaled nitric oxide and epoprostenol to decrease the PVR in such patients. Coming on to Fontan circulation, this is actually done as a procedure for any patient who has got a single ventricular physiology or a tricuspid atresia or a double inlet right ventricle or a double inlet left ventricle or a double outlet right ventricle. Basically, it involves giving this IVC of both sides to the pulmonary artery and also shunting the IVC to the pulmonary artery. So there is no functioning right ventricle to pump the blood against resistance, and these patients do not tolerate any decrease in preload, and these patients will not actually tolerate any increase in intrathoracic pressures, which will actually decrease the preload precipitously. In these patients, depending upon whether their functioning system is a right ventricle or left ventricle, they may have a systemic ventricular dysfunction, or they can even have an AV valve regurgitation and protein-losing enteropathies. These are the very severe manifestations of this disease, and these patients have to be meticulously followed for any arrhythmias which would occur, and pregnancy loss is quite common in patients with Fontan circulation. And these patients are also put on long-term anticoagulation for their benefit. And maternal risk for who have cardiovascular disease or congenital heart disease are at increased risk of developing eclampsia or preeclampsia, and are at increased risk of developing arrhythmias, basically premature atrial arrhythmias or a paroxysmal atrial fibrillation and supraventricular tachycardia and atrial fibrillation. Ventricular tachycardia and ventricular fibrillation are not that common in patients with congenital heart disease, and they are associated with increased risk of postpartum hemorrhage, which these patients do not tolerate well. And they have increased risk of fetal risk, which includes fetal mortality, fetus with low Apgar scores, and recurrence of the same congenital anomaly in the fetus, and risk of preterm babies because of the concomitant decrease in the intrauterine blood flow, and growth retardation is also seen, and small for gestation is also common in patients with congenital heart disease. These patients may be on ACE inhibitors pre-pregnancy, and they should actually be given a pre-pregnancy withdrawal trial of ACE inhibitors to see if they are tolerating the withdrawal of ACE inhibitors. If the patients do not tolerate and land up in failure when you stop an ACE inhibitors, then we should think of pregnancy twice. If the patient is on beta blockers or calcium channel blockers for any decrease in heart rate or in case of an iotopathy, then we have to continue them in the pregnancy and in the postnatal period. Patients who have got a severe pulmonary artery hypertension, or those who have got a Fontan, or those who have got an atrial fibrillation pre-pregnancy or during pregnancy will be put on anticoagulation, and that should be continued as well in the perinatal period. Any life-threatening heart failure which is occurring in these congenital heart subsets should be treated with mother as a priority and not fetus as a priority. Administering diuretics or any patients who will need ACE inhibitors should be put on ACE inhibitors, and then only should be curtailed and treated depending upon their symptoms. Any life-threatening arrhythmias, may it be atrial fibrillation, then we can go for, if they are stable, we can go for a beta blocker, or if they can go for a digoxin, or in case if the patient has got a stable SVT, provided that the vagal maneuvers are not working, we can go for an adenosine. If it is unstable, any arrhythmias, we can go for, if it is cardioversion is possible, we can do a cardioversion. We should always check for fetal heart rate before and after delivering a shock because of the risk of fetal arrhythmias. And delivering a shock should not be delayed if the mother is unstable, even if the fetal monitoring like scalp electrode is present. Coming on to uretotonics, these are subsets which have which must be dealt with caution, because oxytocin decreases the SVR and actually it increases the PVR slightly. These most congenital cardiac disease patients, they actually tolerate oxytocin, and infusion is what is recommended rather than a bolus dose. And an ED95 dose in a study where it was found 16 units per hour has been put, and the uterine contraction has been was being documented. And in case if it is a non-laboring woman, the ED95 was somewhere around 7 units per hour. And it is very, very imperative not to administer it as a bolus in case of a heart disease. Always give us an infusion via an infusion pump. And misoprostol is a least effective uterotonic, and it can be used prophylactically, kept after delivery to prevent further incidence of postpartum hemorrhage. Methyl ergometrin, it increases both SVR and PVR, and hence it is actually contraindicated in any heart disease or pulmonary hypertension as well. And carboprost has a precipitate increase of pulmonary artery pressures to somewhere around 125%, and also has increased risk of bronchospasm, and hence it is contraindicated in Fontan intracardiac shunts, and it is actually most of the cardiac lesions. Administering these for decreasing the incidence or preventing the postpartum hemorrhage, actually the risk is more than the benefit. If at all you want to have, if you have a postpartum hemorrhage, administer oxytocin to the maximum dose possible. Try other maneuvers like uterine massage, battery balloon, or a B-Lynch, which will help in these patients, rather than going for methyl ergometrin or carboprost, which may worsen the situation further. Coming on to inotropes and vasopressors, any patients who wouldn't tolerate a fall in SVR can be administered phenylephrine of 50 to 100 microgram boluses or as an infusion, or norepinephrine 0.02 to 0.08 micrograms per kg per minute infusion, or 1 to 6 microgram per minute can be administered. These doses can be administered in the peripheral line, and it is being tested also that it can be administered via peripheral line. Those patients who are in failure can benefit from dobutamine in the perinatal period as an infusion, or those who wants to have like inodilator can be administered milrinone, and those who want to increase the contractility depending upon the pathology can be administered adrenaline, keeping in mind that there is a pro-arrhythmogenic propensity for these adrenaline as well. Coming on to monitoring in such patients, it should include in the labor room and in the postnatal period, should include ECG, non-invasive blood pressure monitoring, invasive blood pressure monitoring in patients who are under class 3 and class 4 risk, pulse oximetry. In case there is a TTE available, nothing like it as Dr. Amaraja has mentioned, we can actually load the patient with fluids depending upon seeing the contractility and the RV function, if the IVC is collapsible or not. And one thing is to notice to give fluids or not depending upon B lines. Even before CRUPS and things, you can actually go for check in the prenatal period, check in the intrapartum period, and check in the postpartum period whether D-lines has occurred, and you can titrate the fluids with regards to the TTE which is available. If at all the patient is getting general anesthesia, we can go for a transesophageal echocardiography. In patients where you want to have a high central pressures or volume pressure head, then those patients can have a central venous line, and in those who require a constant infusion of inotropes can be put in a central venous line. Pulmonary artery catheter carries a increased risk of arrhythmias, and hence it is not routinely recommended in any patients. So coming on to anesthetic management. In patients with congenital heart disease, loss of resistance to saline is usually preferred because administration of air can have an increased risk of paradoxical air embolism. Also, it is imperative to check for all IV lines to prevent any microthrombi, and chambers which prevents the air with injection should be kept in place. And administration of dilute concentration of local anesthetic like 0.065% or 0.08% of bupivacaine or 0.1% of ropivacaine with fentanyl, like 10 to 25 mics of fentanyl or 50 mics of fentanyl, or if you are giving as an infusion, 1 mics per ml of fentanyl is what is routinely recommended. Because the test dose, if it is intravascular, can actually have a precipitous fall, or it is intrathecal, can have a precipitous fall in BP or a sympatholysis. What is recommended is every dose of a test dose is what is routinely recommended. Any patient who will not tolerate a volume bolus, or any patient who will not tolerate an increase in preload, or who is already in failure because of a congenital heart disease, we do not load them with routine volume bolus, say 200 ml or 250 ml of volume bolus, which would preload the patient if you are giving any symptolysis. So no routine volume bolus is recommended in such patients. We can co-load if at all the patient is developing a hypotension, and if you feel that the patient is hypotensing and because of hypovolemia, then an aliquots of 100 to 200 ml can be administered, tested for response, and then the volume can be adjusted. Coming on to Valsalva maneuver, this Valsalva maneuver during labor against a closed glottis is associated with decrease in preload and also increase in aortic stress, wall stress. Such maneuvers are not advised in patients who have got an aortopathy, which increases the risk of the aortic dissection. Valsalva maneuver against an open glottis, further increase in the intrathoracic pressures and aid in will help in mitigating the risk of decreased preload. And the indications of cesarean section in these patients are mainly obstetric indications. Any patient who is in heart failure, unable to lie, or patients with aortopathy with more than 50 millimeters aorta and decompensated pulmonary hypertension, and patients who have got an aortic aneurysm, which has a likelihood of dissection. And the choice of regional anesthesia or general anesthesia is made depending upon the patient. In regional anesthesia can be administered in patients who have WHO criteria of 3 or 4 also. In patients with 3 or 4, where there is an increased risk, we can go for a sequential spinal anesthesia and epidural, wherein you give an aliquot of say 2.5 milligram to 5 milligram of bupivacaine in the intrathecal space, and load the epidural with 3 to 5 mLs of either xylocaine, or if it's an emergency cesarean section, then it's a xylocaine with adrenaline. Load them, and you can have an increased level of blockade from T4 with the sequential spinal anesthesia with low dose of bupivacaine itself. So this is what is advised in patients who have an advanced degree of failure, where we are actually trying for a regional anesthesia. In patients who have a decompensated failure, or patients who are on anticoagulation, may it be Fontan or pulmonary hypertension, where we don't have time to wait, or of course reversal is not possible at that point of time, then we can go for a general anesthesia. One point which I had to note is exciseration of uterus in during delivery. They have found that there is an increased risk of air emboli in patients who have got right to left shunt, in case where the uterus is exteriorized, and micro emboli has been found via Doppler in such cases. So in patients who have right to left shunt, it is very prudent for the obstetrician to close the uterus inside the abdomen rather than exteriorizing the uterus. And in patients who have got an aortic dissection and who are actually having a hemodynamic instability because of a pulmonary embolism or pulmonary hypertension and severe RV failure or LV failure, these patients are subsets of patients who will actually benefit from a veno-arterial ECMO, and patients who have a dissection can be managed by a vascular surgeon or a cardiac surgeon in the interim period. Any patient whom we think will actually collapse during labor, they can very well have their lines placed before their delivery or any attempt to deliver that patients. Lines can be placed for a VA ECMO under local, and then the patient can be asked to deliver in such, as Achal sir mentioned, in a place where cardiac surgery is possible. And in postpartum period, monitoring for arrhythmias for the first 24 hours to 48 hours is essential, and rule out any postpartum hemorrhage and treat any postpartum hemorrhage which would occur. Continue drugs like anticoagulation once the risk of bleeding is mitigated, and continue drugs like ACE inhibitors and beta blockers which the patient is on. If the patient develops any arrhythmias in the postoperative period, treat him according to the algorithm which is available, and initiate breastfeeding early, because the baby may as well be compromised because of a small for gestational age or be preterm. Thank you.
Thank you, Guru. That was absolutely wonderful revision and update on the congenital heart diseases in pregnancy, basic principles on understanding of the pathology as well as how to deal with them when it comes to anesthesia. I now open the floor for questions. Any questions for Guru, please?
There aren't any questions.
There aren't any questions.
It's such an extensive topic to cover. I mean, it's amazing how you managed to actually cover so many things, Gurusanthiya.
Thank you, sir.
Thank you, Guru, for an excellent presentation. If I may
Thank you,
jump in. I would suggest a couple of things for sure in all patients who have any kind of shunt, left to right or right to left, to use the air filters for any IV line. That is a must. Even if patient is with left to right shunt, when they do Valsalva or kind of strain for any reason, so there is always a duration in the cardiac cycle which can have right side pressure more than the left side, and there can be right to left air embolism causing systemic problem. So number one, always have an air filter in your IV lines, number one, and be very careful injecting any IV medications. Make sure there is no air in the syringe. And number two, we should always think of endocarditis prophylaxis. If patient has any residual shunt, especially or patient is cyanotic with right to left shunt, we should always think of or find that there is endocarditis prophylaxis. Now, there are some red flags in these patients, and they should always be referred to a specialized center. If patient who is cyanotic, patient who has got severe pulmonary hypertension, excuse me, and patient who has got moderate RV dysfunction, or patient who has got severe LV dysfunction. These are very high-risk patients. They should always be managed by, as Guru mentioned, by a group of people like cardiologists who specializes in congenital heart disease, a cardiac anesthesiologist who has some experience in managing these patients, and of course, a trained obstetrician. Our role is mainly in the perioperative period only, and we should make sure that our patient is stable. And again, it is again patient who has got cyanotic, so hypoxia is much worse than heart failure. And so these are a few points which I think are important to discuss. Thank you.
Thank you, sir.
Thank you, sir. Yeah. So with regards to, as rightly pointed out, whether they are symptomatic, asymptomatic, whether they are cyanotic or acyanotic, and whether they come under the modified WHO grading 1 and 2, 2 to 3, or 3 and 4. I think the 3 and 4 symptomatic patients, as well as the ones who are cyanotic, they go to the higher centers. And either way, we need a cardiologist, an obstetrician to optimize them and time the delivery before we actually get involved in these patients. I think we are seeing more and more of the patients who come with corrected coarctation, corrected TOF, women who get pregnant, and VSD, ASD has become very common now. We see quite a lot. Any experiences, anyone who'd like to add or ask anything more?
I think a lot of patients come with pulmonary hypertension. Yes, and that have to be very well managed, and I think we all do manage them very well. Most of the patients are done under regional anesthesia, are managed very well by all of us. The main thing with these patients is the fluid balance, I feel, the oxygenation, and any manures that will increase the PVR have to be avoided, as very well discussed by Dr. Guru. In any cardiac case as such, I would like to say that there are only two complications that we have to be very much meticulous about. Is one is the heart failure, and second is the arrhythmias. So if we are constantly keeping a tab on these two, heart failure and arrhythmias, I think there are very few chances that we might land into problem, and our patients can be very well treated by us.
And timing of anesthesia based on the anticoagulation. I think a lot of them
Yes.
are
In case of regional, yes.
Bridging with heparin, most of them are, or so I think there are a lot of nitty-gritty details for each one of them. But
Yes.
I think three, as she mentioned, as Dr. Amarja mentioned, failure management, arrhythmias, and anticoagulation would be the extra points, and infective endocarditis prophylaxis, in addition to maintaining the hemodynamics and ABC for these group of patients. If there are no more questions, can we move on to the next?
Yes.
I now invite Dr. Dhiraj Bhandari. He's here to talk to us about rheumatic heart disease in pregnancy, do's and don'ts. Over to you, Dr. Dhiraj.
Thank you, madam. I hope the screen is visible. Am I audible? So, I'll be talking about rheumatic heart disease, pregnancy, and anesthesia. Basically, again, the same cardiac thing. And as you would notice over a period of time throughout the presentation, the basic gist, what Dr. Guru and Dr. Bhavya presented, that's excellent presentation, and what we had an excellent discussion over a period of time. Pretty much there will be some repetition because that is the core crux on how we will do cardiac patient management for a pregnant patient for anesthesia and perioperative critical care. So that will be the overall gist. So what I'll be talking about is first thing that there is some misconception that probably there is a decrease in the incidence of rheumatic heart disease and they are not probably a problem anymore. So we need to talk about that. Rheumatic heart disease, the most important thing is the mitral stenosis. So I'll be predominantly talking about mitral stenosis and pregnancy, though I'll touch base upon most of the other things. And lastly, anesthesia management for pregnant parturient with above condition, how we deal with it. I'm not going to go into too much of details of pathophysiology and other details, and I'll try to cover the presentation in brief in the given time period. So if we look at the etiology of valvular heart disease, basically degenerative forms the most common, followed by rheumatic. But if you look at the Indian scenario, the rheumatic heart disease and rheumatic mitral stenosis is probably still the predominant cause, and that is something which we still need to be talking about, especially looking into the low and lower middle income country groups. Now this is an excellent script or a small noting. People have been diagnosing this for a long period of time. They have been able to do it with a clinical scenario, and over a period of time, they have done a quality improvement. Ultimately, whatever we are doing in our day-to-day practice, the idea is that over a period of time, what I did 1 week back, 1 month back, 1 year back, should be over a period of time improving my practice, improving my institute practice. And for that thing, a smaller details, a smaller attention to details become very important. That is how things improve. That is how patient safety and quality improvement programs work. 2015, Government of India especially brought out a handbook on prevention, highlighting that this is a significant problem. We all know that in World Heart Federation has given a high priority to rheumatic heart disease. There are almost close to 40 million people living with rheumatic heart disease, and majority of them are living in low and middle income countries. There is a significant mortality associated, and the most important thing to note is rheumatic heart disease is the most commonly acquired heart disease in younger generation, and most people who die of rheumatic heart disease are under 40 years of age, and this is preventable to a large extent, including the outcome during the pregnancy. Now, if you look at the position statement of World Heart Federation, the strategic goal again is a 25% reduction in premature death from rheumatic fever and rheumatic heart disease among individuals aged less than 25 years by the year 2025. The reason I am putting it here is because as anesthesiologists intensivists, it becomes our significant onus, our significant responsibility to work towards this particular thing. This is a paper from Indian scenario where they talk about valvular heart disease in India, and the rheumatic heart disease and severe mitral stenosis tops the chart, and that is why the predominant focus of this talk will be again mitral stenosis. Again, as I said, I'll not go into the details of symptomatology, but basically a streptococcal bacterial infection to start. If not treated properly, patient lands up in rheumatic fever, and over a period of time with the permanent damage to the heart walls, one progresses to rheumatic heart disease. And ultimately, as we have been discussing just also some time back, ultimately it's the arrhythmias, atrial fibrillation predominantly, the heart failure or the pulmonary edema, which ultimately results in death. The symptomatology, when we talk about rheumatic fever, it is predominantly joint pain and carditis, which is a pancarditis. But when we talk about rheumatic heart disease, we talk about heart murmur, chest pain, breathlessness, easy fatigability. One is very important to know that symptoms of rheumatic heart disease may not be noticed for many years, and many a time they will be coming, they will be unmasked during some sort of exercise, during some sort of event, and pregnancy also can be such sort of event, especially in our setup where the socio-economic status are so variable in the country. People who have advanced knowledge, education, ease of access to healthcare technology, and we have the other spectrum, we might still get, and we are getting a lot of patients who will have rheumatic heart disease presented with advanced disease during the pregnancy, and we need to know how to manage them. So if we look at this cardiac complications and perinatal outcome in pregnant women during delivery, this is in the Indian data. What we can see is new onset atrial fibrillation or pulmonary edema or deterioration of function class is seen as majority of the symptoms, and also it is associated with worsened perinatal outcomes, including stillbirth. Again, not going to go into the pathophysiology, but basically what mitral stenosis causes is a left atrial pressure overload. This gets transmitted backwards to the pulmonary venous system, the pulmonary venous hypertension, it gets converted to pulmonary arterial hypertension, it causes right ventricular pressure overload. There is always a mechanism. So we need to understand the hemodynamic alteration and the structural sequelae. Similar thing we need to know about the pressure volume loop as to how things change over a period of time. Now coming to the main crux of the talk, that is anesthesia management for the parturient. We can talk about pre-operative, we can talk about intraoperative, and we can talk about post-operative. So this particular diagram, all of us have been elaborating on this same diagram: who, what, when, where, how. This is very important. We are all a part of a multidisciplinary team, and we need to be very clear as to what is the ultimate aim for a pregnant patient who is coming to our hospital setup, whether we will be able to deal with all complications at the given setup, or we need to do a higher referral center. And even at a higher referral center, what are the things which needs to be done? I'm not going to go into detail because it has already been covered in depth by Dr. Guru as well as Dr. Vanilla. Now, which place and what team becomes very important. So the modified WHO classification, which Dr. Guru talked about, availability of expertise. Dr. Achal sir has been talking about it. Everybody is talking about it. The basic minimum is at least a cardiologist, obstetric anesthesia specialist. If he's a cardiac anesthesiologist at a background, even better. And then a maternal fetal medicine specialist. This is at least a basic team we should have when we talk about the expertise to handle an advanced level of care. When we talk about availability of infrastructure, we might be having a team, but at times we not be having an adequate ICU facility or adequate operation theater monitoring facility. We need to understand the patient's socio-economic status. Well, it is easy said than done that we should refer this patient to higher centers with considering a very ideal scenario. Sometimes we will have to dial down the back if the conditions doesn't allow, if there is an emergency, and we'll have to see what best out of the given team can be utilized to ensure a best outcome for that thing. And ultimately, the most important thing is, even if you have a fresh person on all these things, experience of a team makes a great difference to the outcome. Now, this is a very nice old paper which I came across. This is almost in May 1947, published in AHA. The concept of a multidisciplinary team is not new. This was something like what they called as the cardiac clinic of the Boston, where it was a cardio, pregnant, and obstetric clinic combined together. They observed that the mortality rate, maternal mortality rate, was 20% to start with. It was a time when it was a predominantly rheumatic heart disease. It dropped to almost under 5% in ensuing 3 years at 1947. So the emphasis on a multidisciplinary team is almost very important, and we need to do this important thing in our own setups and improve the patient safety and quality improvement mechanism. Now, second thing we were all talking about was throughout the discussion also, there should be certain red flags or there should be certain signs and symptoms which we should be able to easily appreciate. Now, there have been many scoring systems, there have been early warning systems, but at the same time, If we raise too much of alarm, all the cases will start getting referred. At the same time, if we sort of under try, that also becomes a problem. So I'll not go into this detail, but this is very easily available. We talk about self-reported symptoms. We talk about vital signs, we talk about physical examination. And when these things are clubbed together, either they can be classified into routine care, that is reassurance, or a caution has to be seen, a non-emergency evaluation, at least in some sort of evaluation has to be done at a higher center, or a prompt urgent evaluation has to be done by a pregnancy team. So this is something which almost all the medical officers, fresh people who have passed out can do, and then they can decide whether this patient needs to stay at my place or whether this patient needs to go at a higher flag. Dr. Achal sir was talking about important red flags. This is basically from the CARPREX score, that is cardiac diseases in pregnancy score 1. These were the 4 important red flags they talked about. And this is very easy to identify, or even at most of the basic centers. Does my patient have a NYHA class 3, class 4 symptoms? Does the patient have signs, symptoms, or echocardiographic findings of left heart obstruction? Example, mitral or aortic stenosis, hypertrophic obstructive cardiomyopathy. Does my patient have prior major adverse cardiac event, say at significant arrhythmia, which was hemodynamically unstable, or a heart failure? And do my patient has a left ventricular ejection fraction of less than 40%? Any one sign increases the mortality and morbidity logarithmically, and when there are more than one sign, the ultimate morbidity and mortality can go in double digits, almost to the tune of 25 to 40%. Now coming to our basic routine thing, when we talk about optimizing these patients, we talk about pre-anesthesia care, we talk about intraoperative management, and we talk about post-operative care. Now the first and foremost important thing is PAC, visit in a PAC, a pre-anesthesia checkup. Now more often than not, you will all agree with me that at least in a government setup or in a resource limited setup, many of these patients present as an emergency, and there is not much you can do in an emergency pre-anesthesia checkup. But if you have these patients who are visiting the obstetricians during the 3rd trimester, it should be ensured that while they visit the cardiologist, they also visit the anesthesiologist during the 3rd trimester of pregnancy. Now, this has been made a highlighting point in Government of India guidelines for obstetric anesthesia critical care module, that whenever possible, elective PAC should be done to identify high-risk cases, not only cardiac, but overall. A patient might have a difficult airway, a patient might have some other respiratory symptom, which needs to be referred to a higher center for a good outcome. We need to talk about history. I'll not go into details, but very important to differentiate between symptomatic and asymptomatic disease. We all know about aortic stenosis. Aortic stenosis, when the disease is classified, we talk about severe aortic stenosis, which is non-symptomatic. We talk about severe aortic stenosis, which is symptomatic. And it almost stands true for all the cases of valvular heart disease, that wherever possible, earlier the patient should be picked up before significant symptoms develop, because once the symptoms develop, the natural course of the disease tends to go downhill without us intervention, and even then the outcomes vary significantly. We talk about history of hospitalization. We talk about past history of any intervention. Was there a balloon valvotomy percutaneous procedure done? Was there a mechanical valve or a bioprosthetic valve cardiac surgery done? We need to know about medication history. Is the patient on anticoagulants? Very important to know. Patient in Indian setup are not very learned. Even though if somebody has gone a cardiac surgery, they will tell you in the front, but this has to be a leading question. And if it is negative, it has to be documented that currently the patient is not on any anticoagulant. Remember, mechanical heart valve is not only the indication, but a patient in the pregnancy with a severe LV ejection fraction, which is less, or an enlarged LA, or atrial fibrillation is also an indication for anticoagulant. Beta blockers and diuretics form the mainstay for mitral stenosis patient. Examination, we can talk about general examination, we can talk about systemic examination, and then we come to the investigation. We'll have routine investigation, but then there are certain specific investigation. BNP, I'll just like to talk about. People do BNP left and right, but again, the value of BNP doing left and right is questionable. If you have a patient who is obviously in pulmonary edema and failure, probably there is not much additional value. to doing a BNP, but it is useful to let you know and help you in the diagnosis. It's probably more important if you are not in a clear-cut picture whether my patient actually has a pulmonary edema or not. Probably BNP might be useful to rule it out, again with a limited sensitivity and specificity. 12-lead ECG, it goes without saying, it is important. And if we talk about the 2020 ACC/AHA guidelines for valvular heart disease, the most important investigation is echocardiography. Wherever possible, if transthoracic echocardiography is good, otherwise we'll have to think about transesophageal echocardiography. I'll not go into the detail of valvular classification, but we many times have a tendency to base our severity classification just based on one number. Say, for example, a mild MS, a moderate MS, or a severe MS. But the guidelines say it very clearly that the severity determination is done by 4 important factors. So this is very important for all of us to know. Patient symptoms, very important. Valve anatomy is important, valve hemodynamics is important. These are 2 different things which are evaluated by the echocardiography. For example, you will have a valve anatomy as to how my valve is looking, thickened, non-thickened, calcification, and valve hemodynamics probed by Doppler. What is my pressure half time? What are my pressure gradient across the valves? And based on this thing, what are the consequences of valve obstruction on the left atrium and pulmonary circulation, whether there is an element of pulmonary artery hypertension or not. The reason I have put the right-sided diagram here is the valve hemodynamics can change significantly in patients who have a natural volume overload. For example, pregnancy, all we know is a stage of a volume or a overload where we have an extra cardiac volume circulating. The heart rate varies, and valve hemodynamics significantly depend upon heart rate, cardiac output, and the diastolic filling time. So surprisingly, the same values which we use during pregnancy, a single value will not be useful, but a constellation of whole symptoms will become very important. Thus, to highlight this point, the definition of severe mitral stenosis is based on the severity of the symptoms as well as the severity at which the intervention will improve the symptoms. I'm not going to go into this detail, but basically 4 stages of severity of mitral stenosis: A, B, C, D, or as we call it, at risk of MS, progressive mitral stenosis, asymptomatic severe mitral stenosis, or symptomatic severe mitral stenosis. Now, one more important thing to note here is in valve anatomy, the valve anatomy is clearly mentioned. If it is less than 1.5 centimeter, we talk about severe. 1.1 to 1.5, we talk about moderate severe, but for pregnancy, it is slightly different. Now, in asymptomatic versus symptomatic, you will have an elevated PASP, that is pulmonary artery systemic pressure. You will have a LA enlargement, but the symptoms are yet to appear. And when the symptoms appear, this is almost like one of the highest or the severe grade of pregnancy. I'm highlighting this point again. During the pregnancy, the valve area, even less straight away, less than 1.5 centimeter square, has been defined as a severe or clinical significant MS, which includes even the valve area of 1.1 to 1.5 centimeter, which was considered to be moderate MS in earlier outcome studies. This becomes a bit easier for us to remember as well. I'll not go into detail, but just wanted to highlight one point. Just because it is a mild or moderate severity of MS, that doesn't mean that the complication will not happen. Probably the mortality will be less, but the morbidity, including pulmonary edema, new arrhythmia, heart failure, will still be a possibility, and all cases need to be treated with utmost care. Again, the same thing, heart failure about mild, moderate, and severe. So if you see in severe, there will be almost significant, but it is not touching 0 in mild or moderate MS. That is the point I'm trying to highlight. Dr. Guru had talked about modified World Health Organization classification. Now, the point I am emphasizing here again is I have done my pre-anesthesia checkup history. I have done my PAC examination. I have done my examination. Now I have overall a picture. That picture needs to be put into some sort of a classification. We do ASA classification, but there's a specific modified World Health Organization classification of pregnancy. I'll not go into the detail, but basically classified into 4 diseases. And important to remember that WHO category 4 is severe mitral stenosis, severe symptomatic aortic stenosis, pulmonary arterial hypertension, and severe LV dysfunction. The 4 important points which I had highlighted earlier, they straight away fall into the modified WHO highest risk. Ideally, if you look at here, pregnancy is contraindicated, but it's an individual choice, and pre-pregnancy optimization needs to be done. So to a question at the start of the symposium that when the pregnancy has to be aborted in other indications, probably this guideline helps again significantly. Now, this is a CARPREG 2 risk predictor score. These are very easily available, but essentially they talk about same history, examination, and investigation. Now, coming to the second part, I have done my preoperative part. It was a multidisciplinary collaboration. Now I am preparing my patient for an intraoperative parturition. Now, the most important thing is elective versus emergency case scenario. This is something we should try and change over a period of time, and it will not happen overnight. Despite many quality improvement programs, even in biggest of tertiary care centers, you will still have patients presenting in emergency, probably no PAC done in the past, and they will land up in emergency fetal distress, where you have probably much less to do. They are almost in an advanced stage, and all you have to do is manage the patient in the best possible way at a given scenario. OT setup needs to be done, cardiac drugs loaded, the team has to be there very clearly, preferably a senior obstetric anesthesiologist who is dealing with this case. If he has an experience in cardiac anesthesia, well and good. And I think the MD programs at most of the places, they do give an exposure to cardiac anesthesia, and this again comes very handy. Of course, informed risk consent has to be taken. So I'll not go into these changes. We all know there are significant hemodynamic changes which occurs during labor, the peak stage of labor, and we need to be very clearly be ready to mitigate their impact on the cardiac outcome. Now, this is one more thing. Probably this is again an important point in anesthesia management, not only for cardiac anesthesia. Any anesthesia, at least a major surgery, if you are planning, it is very important that we chalk out our goals of anesthesia. And as per those goals of anesthesia, we do a proper planning of anesthesia. If it's a cardiac case, we talk about 5 important things. That is a heart rate. Then we talk about rhythm, then we talk about preload, we talk about myocardial contractility, and we then talk about afterload for both ventricles, that is pulmonary vascular resistance and systemic vascular resistance. This is a very common case scenario in all day-to-day examinations. All of our anesthesiologists at some point of time, I'm very sure that they have anesthetized this patient. So I'm not going to go into details again very much. But if you look at a gross management of goals, aortic stenosis and mitral stenosis, pretty much the same. The idea is to avoid tachycardia, to try to keep the sinus rhythm so that the atrial kick, which is very important to maintain the left ventricular preload, becomes very important. Preload, it is very important that this notion be very clarified. Most of the anesthetists, they will talk about a restrictive fluid. They might not even give the necessary fluid. So rather than talking about restrictive fluid, we should talk about judicious use of fluid. Patient might be bleeding for some reason. The patient might be anticoagulated, and still because it's a cardiac disease, we might not be giving adequate load to the patient. And that is also not useful, because in short term, a decreased preload will cause the cardiac contractility and the heart rate to increase, and a vicious cycle. So ultimately you are not helping. Afterload needs to be maintained for both aortic and mitral stenosis, but for aortic stenosis, additional severe persistent hypertension should be avoided, because your left heart will be pumping against that. And as Dr. Amarja was talking about pulmonary vascular resistance, in almost all cardiac cases, we should be able to try to see that the routine exacerbators of PVR, that is hypoxemia, hypercarbia, acidosis, dehydration, should be avoided. Now, just a word about valvular heart disease and stenotic disease. This is from the 2023 guidelines. Now, you look at the wordings of this thing. For valvular stenotic valve disease, the anesthetic plan, they say a carefully titrated neuraxial anesthesia can be used. That is very important. Now, what we confuse with neuraxial anesthesia is many times in a sort of a generic language, we say neuraxial anesthesia is as good as a routine single shot spinal anesthesia. No, this is the concept which Dr. Guru was talking about, which everybody has been discussing previously. It can be a graded, slow titrated epidural, or a very low dose spinal followed by graded epidural. We'll come to that part. So monitoring, we know all about. Basic monitoring is very important, as is essential in almost all the society guidelines. A continuous presence of senior anesthesiologist should be there. It should not happen that I have anesthetized this case, my junior is monitoring, and I go at some place. That is probably not acceptable, isn't it? Invasive monitoring, again, it depends upon what you need. Arterial line monitoring becomes very useful if you have it. It is easier done, especially if you are planning a neuraxial anesthesia where hypotension might be a problem. A beat to beat blood pressure monitoring becomes very important. Central line monitoring versus usefulness for medication will not go into detail. The most important thing is transthoracic echocardiography or a POCUS. It's handy, non-invasive, and can be repeated to see the trend and response. As Achal sir and Dr. Shiv sir was talking about, you don't need a fancy dedicated cardiac machine for that. Even a basic machine where you can actually eyeball a sort of a what is happening to my LV is something which will be still useful for you. Now, two important things: choice of anesthesia for a given procedure and choice of delivery. When we talk about choice of delivery, our obstetrician, and even for that matter, we need to be very clear that it is not always that all the cardiac patient needs to be delivered by cesarean section. This is one big important thing which we need to be very clear. In fact, vaginal delivery is the preferred mode, and choice of anesthesia will soon talk about neuraxial versus general in terms of valvular heart disease. Now, vaginal delivery is preferred. Preferably, it should be a passive, that is second mode. That is what Dr. Guru was talking about, the Valsalva effect, or it should be an assisted delivery. Most importantly, if possible, a neuraxial labor analgesia, if given in a low concentration dose, it will actually be useful to decrease the catecholamine surge, which is very important for this patient. Caesarean delivery is only indicated for obstetric causes and not only for clear-cut cardiac causes. Obvious cardiac cause will be an acute alveolar failure, which is almost needing an intubation and ventilation, or a patient who is presenting in an emergency, say on a mechanical wall, or a say atrial fibrillation with vitamin K antagonist, and there you are not having a time to reverse the antagonism. This fetus will have a chances of intracranial hemorrhage when they are passing through the birth canal because of compression. So probably these are the few indications for cesarean delivery. Now, neuraxial versus general anesthesia, I'm sorry for the spelling. Neuraxial is preferred. Neuraxial doesn't mean single shot spinal. On the contrary, it is useful to talk about graded epidural or combined lodospinal and segmental. Contraindication, which we know, absolute. If the patient is on anticoagulation and you don't have the correct timing between anticoagulation and initiation of a neuraxial anesthesia. Now, severe MS and severe symptomatic AS, people can debate about all these things, but most of the literature still say at least a single shot spinal anesthesia should not be considered. So when I talk about neuraxial anesthesia, here I mean to say a single shot spinal anesthesia. Moderate disease, the literature exists, but more important is the experience in handling cases. I'll not go into detail. Dr. Guru has already talked about the way you can give. The best way is avoid adrenaline, use opioid and local anesthetic. So if you are using a opioid, say 50 mics of fentanyl in an initial test dose, if that has become intravascular, you will notice the patient has become sleepiness or the fentanyl symptoms will appear. And if the local anesthetic is intrathecal, you will notice that the patient has become into a spinal anesthesia. Secondly, give the doses graded epidural very slowly. One of the example can be, say, 5 ml bolus with a gap of 3 to 5 minutes in between. So almost every bolus or every drug which you are giving will act as a test dose in itself. Important thing when you are using a neuraxial is you should have phenylephrine loaded, or many people, they will prefer to have a low dose infusion, and this is probably an indication for judicious fluid use and for having an intraarterial line. Now, about general anesthesia, the opioid and Zylocard, which people say to be avoided in neonates, in obstetric pregnant for respiratory depression, but should be used here in general anesthesia. Choice of induction agent, we all can talk about propofol, ketamine, or the combination etomidate, depending upon what is available and what the current indication is. Regional anesthesia, if you get a chance, preferably prior to the surgery. Laryngoscopy and intubation response should be blunted. Nitrous to be avoided in all these cases because they will have some amount of pulmonary arterial hypertension, and all the vasoactive medications to increase or the decrease the blood pressure should always be kept. People forget many times about extubation. Extubation is also equally a sympathetic response and should be very, very well titrated. Anticipate the complications, surgical, anesthetic, and routine. The most important thing is arrhythmias and pulmonary edema, and they will precipitate each other or they will go into a vicious cycle. AF will precipitate pulmonary edema, and pulmonary edema, because of the irritability, can lead to supraventricular arrhythmias. Oxytocin, Dr. Guru has already talked in this area. Infective endocarditis prophylaxis, very important. The guidelines are detailed. As much as we like to say, the guidelines have now become very restrictive use, but major mechanical valve, bioprosthetic valves, or with or cyanotic non-corrected diseases, we need to give infective prophylaxis. And the surgeons, which they are using a surgical site infection prophylaxis, that same prophylaxis will automatically be useful for infective endocarditis prophylaxis also. I'll not talk about intraoperative. This is something we talked about pregnant patients towards the term. There might be patients who had pregnancy already going into advanced stage. They were not aware about their valvular heart disease. And now during the first or second trimester, the symptoms have exacerbated. And this patient might, despite best medical management, they are not able to undergo symptom relief, and they might need some sort of a intervention. A percutaneous balloon valvoplasty is something which is mostly commonly done. You will need anesthesia support for this valve. I'll not talk about the non-native valve consideration, that is bioprosthetic and mechanical valve. But the most important thing when we talk about the women with a mechanical heart valve during pregnancy is to talk about anticoagulation. Anticoagulation with warfarin or anticoagulation with heparin. The preferred approach is that because of warfarin, there is a fetopathy or embryopathy, and people would switch to a low molecular weight heparin or unfractionated heparin. But at the same time, low molecular weight heparin and unfractionated heparin have not found to be that strongly effective to prevent the thromboembolic complications. So there are many regimes. One of the guidelines from 2018 says that if the warfarin doses are less than 5 milligram required, probably can consider continuing warfarin throughout the pregnancy. So this is one of the things. Ultimately, despite whatever we are choosing, 36 hours prior to the planned delivery, we should transition these patients to unfractionated heparin, and 4 to 6 hours before the delivery, the heparin should be stopped. And then based on this thing, our neuraxial anesthesia based on the ASRA guidelines or AOA guidelines can be established. Post-operative consideration, again, HDU, ICU care, multidisciplinary care, and restarting the anticoagulation is there. Very important to have baseline evaluation and discharge for counseling. Now the counseling part is something we think that it is not our thing. This is a pre-pregnancy counseling, but towards the end of a first pregnancy, we are the people who are dealing with this patient for a longer period of time. We have seen them at their most critical junction. So probably if we are also giving them a counseling that before you plan the next pregnancy, think about getting a consultation of obstetrician and a cardiologist, probably this will be very effective, and this should now become a part of our moral responsibility. I'll not go into detail. These are just few of the anecdotes, but what they say is the good results encouraged us to believe that the judicious and skillful management of similar condition will decrease the risk associated with lesion. Very important to know counseling of the patient. And lastly, the signs which are looked upon suspicion, they can be innocent as well as grave. Many women will be subjected to unnecessary alarm and restrictions when they are pregnant, and other will have the suppress the natural desire of motherhood. So we need to be very cautious as to what we are counseling them, as to what we are treating them. And lastly, when you talk about a multidisciplinary, there will always be some sort of discrepancy. The cardiologist will think that the pregnancy is complicating the pre-existing heart disease. The obstetrician thinks it's the patient pregnancy which is complicated by the cardiac lesion. So we all need to come at the table, sit together and sort out our differences. I'll not go into this detail, do's and don'ts, because this is pretty much the summary, what we had talked about. But basically have an earlier PSC, talk about multidisciplinary team, talk about a modified WHO classification, vaginal delivery to be encouraged, and in all cases of anesthesia, goals of anesthesia to be clearly planned. So these are the sustainable development goals. Till we don't decrease the rheumatic heart disease associated mortality, we will not be able to achieve the SDG 2030 goals, and we play an important part into this thing. So thank you very much.
Thank you, Dr. Dhiraj. That was absolutely a very good presentation and very good to hear you as always. It was comprehensive, beginning with the incidence, prevalence, and why this disease is still so important even after so many years, because we are still seeing plenty of them. Thank you for a wonderful presentation. I'm sure everyone's enjoyed that, and the students who are listening have benefited as well, because it's one of a very important question. Anyone has any question for Dr. Dhiraj? No.
No questions on the YouTube.
No questions on the YouTube. Okay, great.
I would like to add a few points.
Yes.
First and foremost, Dr. Dhiraj has a very good flow always when he talks, and that is something which we appreciate. Secondly, I just wrote a line from his presentation on my notes also: continuous presence of anesthesiologist. Yes, which is very important. Even if the patient settles down eventually, our continuous presence there, and that too meticulous management has to be done by us throughout the case, and even in the early post-operative period. Nothing can be taken for granted in these patients. Then antibiotic prophylaxis or antibiotic pre-operatively is very, very important for two things. One is endocarditis, as he has already told. Second is the infection. Yes, we have to be careful about the infection also, post-operative infection. Secondly is these patients are always into atrial fibrillation. Most of the times you find them in atrial fibrillation. Even if you give the treatment for atrial fibrillation, it is not possible for them to revert directly to sinus immediately, because this is long-standing atrial fibrillation. So the fast ventricular rate has to be come down to slow ventricular rate. So our beta blockers, what they will be doing, it will convert the FVR, that is the fast ventricular rate, into SVR, that is the slow ventricular rate. So that is something we should be aiming for. Immediately sinus rhythm doesn't get converted, like, so at least convert the FVR into SVR. Okay, SVR is slow ventricular rate. Then thirdly, he talked about the myocardial depression. That is also very important. Knowingly, unknowingly, our volatile agents are myocardial depressants. We keep them on 3 or 4 isoflurane. Isoflurane, which is cardiostable, is also a myocardial depressant when given for a longer duration on higher rates. Okay. Then fourth is he told about the induction agent, and he particularly mentioned about propofol. But we have better induction agents like fentanyl, combination of fentanyl or opioids and etomidate or midazolam. You can just combine them to avoid the side effect of that particular agent. So when we talk about AS and MS, we usually don't want the hypotension that is created by propofol. So we can have a nice combination of 2-3 agents to avoid this hypotension. These are the few points from my side.
Yeah, thank you, Amarja. Thank you, Amarja, for your points. I think the guidelines are pretty explicit, and the choice of agents, and as he rightly mentioned in one of his slides, it's not just the knowledge of the drugs, it's about how we use them, and the experience matters. So I think that way the choice of drugs may differ. Rate control, anticoagulation, and managing the hemodynamics, that would be the crux. Any other points to add from the, yes, Shiv?
Amarja just mentioned, use of midazolam and fentanyl. But then if this is going to be a pregnant lady, then you also need to be sure that a pediatrician is available in the theater with reversal agents. Okay. So I think these kind of things, facilities may not be available in the remote areas, in poor resource centers. So I think they have to be very careful. I think there's still graded neuraxial anesthesia, still I think is a safer option.
There is significant literature coming for ketofol also in these cases, sir. Like just to balance out the effect. So based on the duration, if it's a simple non-pregnancy surgery, say for 2 hours, 4 hours, even for that matter short duration, we can straight away have an opioid-based induction and post-operative line. Not worry, probably if needed, I'll just put the patient on some sort of ventilation for some hours. But for a obstetric patient, that becomes an issue. And if we don't have the facility for neonate and everything, we slightly, so it depends upon ketofol or etomidate if it is available easily. It is absolutely wonderful.
I think there is more. I mean, ketamine is quite widely used, but it has to be used in the right way. So we have to use it in the right way.
And I think at the end of the day, we are still into that medico-legal conundrum, sir, where we talk about ketamine being given, and even if it was like, say, 5 to 10 milligram of a dose, that might be held in the court of law that it is a contraindication not to be used. Same happens with neuraxial anesthesia, might be a mild MS or to start with without a significant hemodynamic, but some expert opinion going from a particular place. And if they don't agree, they might put it in the sense that, okay, it was a contraindication and that is probably led to the whole thing. So people, ultimately people will come out of that, but that takes a certain amount of time, the court procedures and everything. So what I've seen is the major consideration when they do all these cases is that, okay, the academic things are definitely at one side, but at the same time, till the practice has been not very clearly established, just like segmental spinal, it will take certain time. If it has not been very widely established, people will still tend to go with the old traditional teaching that at least in severe cases, I'll definitely avoid single shot spinal anesthesia, neuraxia, if you want to give. That is probably the bottleneck, I think. It will come out slowly.
But wouldn't ketamine be with the stenotic kind of lesions be an ideal agent to actually use? Because I have in trauma patients, I have actually used that as an infusion as well, despite the fact having giving blocks and everything. Just use a low dose infusion along with GA. And they provide analgesia as well as provide the systemic vascular resistance. So maintaining the hemodynamics much better.
Yeah, can I also jump in? I came back.
Oh, Dr. Achal, welcome back.
I had to take my dog for a
couldn't stay away
because he was a little impatient. I remember it's related to cardiac, but that is generalized to all specialties. I clearly remember presenting my journal club when I was a senior resident at GB Pant. It was 85, I think, 84, 85, about a landmark article by Slogoff and Keats. Does the choice of anesthesia matter? And that was related to cardiac, but I can hypothesize or put it in any situation. So they had studied high-dose ketamine for coronary artery disease, isoflurane, which at that time was criminal to use in cardiac because of coronary steel at that time, a balanced anesthesia, and a high-dose narcotic. And their end result was there was no difference at all in the outcomes. And their final line was, it is not the anesthetic agent, but it is the person using that agent is more important. So for OB, I think I would go for regional or neuroaxial as far as possible. Though I'm not an expert, I should be very honest. But we can always manage the side effects of those side effects of spinal or epidural by something else, unless it is contraindicated. And for contraindication, as Dhiraj and everyone mentioned about anticoagulation, and I will also want to highlight here, though it is not very common, it is rare, that is cardiac cirrhosis. So if patient who is in heart failure or who has a Fontan circulation with big liver, so we should always look for any coagulopathy, INR, PTT, or portal hypertension, which can again cause problems with the epidural veins being engorged if patient has portal hypertension because of cardiac cirrhosis. I just wanted to highlight that. Thanks.
Thank you, Dr. Achal, for joining back in and giving us some valuable points. I think we can go on with this discussion. It's such an interesting topic. Any more questions? Any more questions on the YouTube? No.
No, we can ask the other faculties. Dr. Hemant is there as well.
Yeah.
from
Bhandari.
cardiac and other people. If you wish to join, guys, you can actually join in the last few minutes before we go off the live on YouTube.
Preeti ma'am
And
was
if he is
asking,
interested in joining, he can join in.
I think Preeti had asked.
Preeti madam
Preeti,
has
would
asked
you
a
like to
question.
ask?
Yeah, hello everyone. Fantastic presentations. I did miss the initial half today, unfortunately. And I have put up my questions. I don't know who will answer them, whether Dhiraj would be a good person. My question was regarding the BMW. We used to do a finger mitral, or a balloon mitral valvotomy during this, when the patients usually presented in an absolutely decompensated state. Now, this is, I'm talking about a tertiary institute in Mumbai. So our patient would have traveled from some other place, come absolutely breathless, sometimes in pulmonary edema, often bringing out pink froth and requiring a C-section at the same time. Now, if such a patient were to come to you and you were in a peripheral area, of course, there's not much you can do. But is it still being done? Because I do not see such patients in my circle of practice, actually.
Not at our setup, madam.
I have also not seen like during a cesarean section doing a BMV, but yes, I have seen a 8-month gravida getting a BMV done. And then next her she might have landed in a cesarean section or a normal delivery, but up to 8 months I have seen a BMV.
So even 2 weeks prior to term, we saw one lady come in and the baby was doing
BMV is done.
Started on anti-failure, went for BMV and came back for normal delivery under epidural, went uneventful. So I think we have seen, but on table I have not done anything together so far.
Yes.
Yeah, when the patient comes electively to you beforehand, yes, you can sort of try and correct the cardiac issue first before they come up for delivery. But I'm talking about these emergency patients who have come and they are breathless and the baby is in distress. And, I remember doing at least 3 or 4 such cases, but this was way back in the late 90s. Now, after that, in the last 23 years, I've not seen any. So I was just wondering whether anybody comes across such patients anywhere in their practice. Not at all. And second question I wanted to know, I was thinking about the option of a targeted segmental spinal in these patients vis-a-vis to the cardiac issues that we have and the cardiovascular stability that we need.
Ma'am, I'd just like to intervene here. In our center in KGMU around 2 months back, there was a patient of severe AS and she underwent a parallel cesarean section, and after that they put her on bypass. So it is happening, but she was optimized very well pre and post-op, and she made a very successful recovery.
Hi, can I interfere a little bit?
You can interject. Hi, Dr. Hemant.
Hi. The intervention during pregnancy, just wanted to mention 3 patients which we did in Chitra, and we presented that in one of the journals. 28 weeks or 30 weeks pregnancy, and all 3 of them came with the severe mitral stenosis in pulmonary edema. Now we had all 3 of them had AF, so there was no question of doing any balloon valvotomy. So we explained to the relatives the possibility of premature birth and everything, and we had to take her on bypass and do the open mitral valvotomy in 2 patients and 1 mitral valve replacement. Our obstetricians, because our institute had no obstetrician, because we only deal with cardiac and neuro cases, so we got obstetrician from the medical college hospital, which is just across, and she was always there. Now, what we did in this case is although hemodilution was the main factor with the PCV, usually we accept PCV around 20 to 24, and here we accepted about 28. I'm talking about circulating PCV. And the cardiopulmonary bypass rate, that is machine rate, is usually 2.4 liters per meter per square. Here we went up to 3 liters. But we knew that with this high rate, there will be some destruction of the blood and blood elements. But we managed very carefully with the mannitol and other Lasix infusion and all. And successfully we saved both mother and kid. And ultimately, the obstetrician decided to do a cesarean section at the end of 34 or 35 weeks, because according to the tokometry, the child was getting heart rate was variable. But my point was, if you do it properly on the cardiopulmonary bypass with the higher flow rate and the management of PCV, the chances of premature birth may be avoided, provided you give some drugs. Like that time we have only Proluton or something. I still remember Duodilon depot was given to all these patients, and it went up well. So that is my input to all this discussion. So cardiopulmonary bypass is not all that dangerous as we think. It can be managed easily, provided you have all the facilities.
As again, it's the right hands at the right time, and the outcome varies based on.
No, we could have done it balloon valvotomy, but it was not possible because of AF. All patients were in AF. And we could take out the thrombus from one patient. On 2 patients, we could not see anything. Another patient required anyway MVR. So that was a different issue, because the valve was totally damaged. It's all calcified, fibrotic. Even subvalvular apparatus was gone. But all of them were saved along with the kids. No mortality.
Dr. Hemant, so are you saying that for balloon mitral valvotomy, the patient need to be in sinus, cannot be in AF?
Yeah, because then you have no control. Suppose balloon valvotomy you do, because it's nothing but the rupture of the chordae tendineae or the perimeter of the valve, or rather valve area. So after that, suppose, and when balloon valvotomy, when you're doing, if you're stimulating the thrombus there, which is very friable tissue, you may end up in. I think it should be one of the absolute contraindication for BMV if there is a clot inside.
Clot or AF, obviously, very common with AF.
So only thing is you could do an OMV, open mitral valvotomy, remove the clots, or go for valve replacement or repair nowadays. So which is you can save the valve. But most of the rheumatic heart disease, you can't save the valve. It is you have to excise it. It's so badly calcified and fibrotic, because we are not seeing myxomatous degeneration like what we see in West, where rheumatic fever is hardly known. But in our part of the world, natural rheumatic fever is very common, and it is impossible to repair those valves.
Very true, sir. I think that Wilkins score will give that clear-cut indication and contraindication. If it's a bad valve, lot of thickening and calcification poor, the valve apparatus is not good, people, they will not prefer, I think, the valvoplasty.
For valve repair, you need to have a chordae tendineae.
Not the repair, sir, for the whole percutaneous BMV, sir.
No, BMV is, it's a desperate attempt. Even if the valve is calcified and all, you just take a desperate attempt as far as such types of patients are concerned. Those who you cannot manage, then you desperate situation, you do BMV. But absolute contraindication is, even AF is not contraindicated, but thrombus in the LA is contraindicated.
Contraindication.
It's like for any postgraduate to say that if you have mitral regurgitation, that's what you're creating. From a mitral stenosis, you're actually making it a mitral regurgitation. And regurgitation, any kind of regurgitation lesions are easy to manage for anesthesia purposes.
True. Correct.
Yeah, correct, sir. Absolutely a stopgap sort of a condition, situation wherein it's like, when you have a fracture, you just put in a slab and stabilize it with whatever you have till you take corrective measures to actually repair the fracture. So, yeah.
With permission, can I make one comment on postpartum cardiomyopathy?
Yes, sir.
Yeah, the postpartum cardiomyopathy, when you diagnose beyond by exclusion technique, and naturally you have already mentioned so many times it's a exclusion diagnosis. It cannot be a obstructive cardiomyopathy. It has to be dilated cardiomyopathy. As Amarja mentioned that the treatment is exactly opposite. But if you know the treatment of dilated cardiomyopathy, it is well and good, because obstetricians, I'm not saying that they are not brilliant enough, but usually they get into problem when they have a patient with a dilated cardiomyopathy. Most probably they have not seen obstructive cardiomyopathy. So dilated cardiomyopathy is the only, because of the weakening of the heart muscles. It's just myofibrils just dilates and they are unable to contract after the dilatation, and hence they get into EF of 55, 60 to suddenly down to 10 to 25, and it takes long time for them to recover. If the recovery is early, within 2 to 3 weeks, they recover quite well. If recovery is more than 1 month, it takes more than 1 month, then the prognosis is very bad. And one should advocate such patients not to have another pregnancy in future life. That is very important. In fact, again, the same thing happens with the mitral people. I mean, if you are undergoing MVR or something like that, replacement of the valve, whether it is usually during childbearing age, you always go for different valves, in the sense you end up in having a tissue valve. But tissue valve, because you don't give any anticoagulant to them. So once they finishes their childbearing age, then the problem comes, because by the time they finish the childbearing age, it is almost 12 to 15 years of life they have spent, and now the calcification starts. So that is actually, what should I say, it's a double-edged sword. You preserve their childbearing age by giving tissue valve, avoiding anticoagulant, and then you end up in redo surgery, which has got its own issues like morbidity, mortality is very high, morbidity is very high. So, I mean, nowadays surgeons are so good in their technicality that it doesn't happen that very often. But still, second time surgery means anyway you will be in trouble. So majority of the time when we were in Chitra, they used to prefer disc valve. I mean mechanical valve, saying that okay, let us breach that time, and then warfarin and heparin and all. But the chances of redo are much less in metallic valve than the other valves, and it is but natural, because they can't afford to undergo second surgery as well. So it's a very tricky and complicated situation, especially. I don't know why God has given to females, but they have to suffer it in case they get.
I mean, that's why we say that there is nothing like, we call it normal pregnancy, but pregnancy isn't a normal physiological thing.
Yes,
It's physiological, but it's not actually physiological.
Very few are physiological nowadays.
We call it physiological changes, but what are physiological changes?
I know, it's terrible. Look at, I mean, when you look at the auto transfusion, as soon as the delivery is over, suddenly 400, 500 ml of blood is returned back to the mother. I mean, how much stress the heart will have. And in top of that, if you have stenotic lesion, you should have to be very careful.
It's amazing what they say on table, because the more we see the cardiac patients under regional, more they express the symptoms when there's a return of cardiac output, every drug action, they explicitly tell all the symptoms, and you're going through the physiology, pathology with them as you sit next to them and talk to them. And you're trying to listen to them, so that, because what they say gives you the cues to what's going to come next. Yeah, I have one question from Pallavi here. Has anyone dealt with primary pulmonary hypertension in obstetric practice? If so,
Dr. Achal had already I think written the answer that.
Yeah, he's done one. Yeah, we have done one. It was quite severe. We had to treat her and deliver her under epidural. Actually, I can share with you that Pallavi. I think we do get such cases.
Yeah. Thanks, Vanilla. Yeah, I have had the experience of treating one patient with Eisenmenger's, and we had done epidural as well for that one. I've published that case as well. But yeah, PPH is something which they have been told not to conceive ever in life. And then they, due to the familial pressures and all, they do land up in that sorry state. Yeah. Yeah.
And
Thanks.
so
Thanks.
desperate to have that one hair. Yeah. It's really amazing what they go through. I mean, I guess that's nature and we cannot do anything about it.
Yeah.
This
They do say that it's the
Eisenmenger,
second. Yeah.
sorry, Eisenmenger could go up to the full-term delivery. It was very
Yeah, this
unusual.
patient survey got in I think she probably came in at 35 weeks. Yeah, she was a very frail woman. Probably, she probably never managed to gain enough weight. She was barely like 45 kilos. And I kept feeling sorry for her, but we had to do our bits. And later we moved her after she had the section and the baby. We moved her from the center where I was working to a tertiary center, obviously because we didn't have a cardiology backup. We didn't know what to do with her. What if she lands up in failure? So she was stabilized over 2 days and then sent back to Nagpur. Yeah. That's why they say it's typically a second life for women, like all what you mentioned, having an auto transfusion and everything. It's just typically second life.
like physiologically, they say, for example, uncorrected tetralogy, which always have an hypoxia, or single ventricle. They cannot reach to the in their life to have a complete.
I think her primary pathology was a big ASD, and that's how she landed up with Eisenmenger's. Never got treated, so her primary pathology was ASD.
It's a crime that ASD is going into the Eisenmenger. It's so treatable. I mean,
exactly.
It's a real crime. If it is a VSD, we accept, but ASD should not be going into Eisenmenger because it's a crime. It's so easily
never
treated.
present.
They never present. Yeah.
They just assume that they compensate so well, and only during pregnancy when they have symptoms. And a lot of this shortness of breath is also masked. They just think I'm pregnant, so I'm short of breath. And unless somebody actually puts a step or they get really sick, they don't actually complain. I think that's the sorry state of affairs predominantly, even in city population, women, you have the extremes where ones who complain about everything and the ones who never complain. So. Thank you. I think it was
thank you very much. It was nice.
Lovely session this evening. Thank you to primarily for this platform on Gas Symposium and all the faculty members who've been wonderful. I'm so glad we waited for another week. I think thanks Bhavya, Guru and Dhiraj, because we were originally planning this for the last weekend and then we had to just get it right, the right speakers for the right topics, and I'm so glad we did that. It was a wonderful session. I learned a lot and I revised a lot in my head. And I hope the people who are listening to had a good learning session. Thank you, Shiv, for this opportunity, and thank you all the wonderful faculty who joined in on a Sunday.
Thank you, everyone.
Thank you, Bhavya. Thank you, everybody.
Thank you, everyone, and have a nice day.
Marja.